Ladies and gentlemen, we are ready to start with the poster presentations. The first poster is titled Study of Pharmaceutical Residues of Carbamazepine and Diazepam in Surface Water, Wastewater and Drinking Water of the Colombo District. The authors are GmbH Vijayasinghe, Manapperuma U, Thambavita D, and the paper is going to be presented by GmbH Vijayasinghe from the Department of Pharmacology, University of Colombo. Over to you, Ms. Vijayasinghe.
Good afternoon, everyone. My poster is on study of pharmaceutical residues in selected surface water, wastewater, and drinking water of Colombo District. Studying pharmaceutical residues in the environment and their adverse impact on the ecosystem stability is referred to as ecopharmacology or environmental pharmacology. Environmental pharmacology is an emerging science, and in recent years, many pharmaceutical compounds have been detected in wastewater, surface water, groundwater, and even in the drinking water samples from nanograms per liter up to micrograms per liter concentrations. Presence of pharmaceuticals in environmental water sources is a great health concern among specialists involved in healthcare and environmental sciences. Antibiotics, lipid regulatory agents, anti-epileptic, contraceptives are the commonly found drug groups in environmental water bodies. Long-term exposure to higher concentrations of pharmaceuticals can cause significant or unnoticed adverse effects. Therefore, it has been identified as micropollutants by the World Health Organization. In this research study, carbamazepine and diazepam concentrations in selected environmental water samples were determined. This study was one of the few studies conducted in Sri Lanka to detect pharmaceutical residues in environmental water samples. And this is the first such study conducted to detect carbamazepine and diazepam in water samples from Sri Lanka. As shown in the poster, studied water samples were collected from 3 selected water bodies in Colombo: Norris Canal, Beara Lake, and Tap Water Distribution System of National Hospital of Sri Lanka. Then, collected water samples were treated according to the method shown in the poster. Solid phase extraction method was validated for the correct extraction of the medicines with recoveries greater than 90% and was used for sample pretreatment. The analytical method to determine the pharmaceuticals was validated according to the criteria given in the ICH guidelines for its selectivity, linearity, range, limit of detection, limit of quantification, accuracy, and precision. Using reference standard solutions of carbamazepine and diazepam in water methanol mixture. Method validation results are shown first in the results section. Next, carbamazepine and diazepam concentration in the samples were determined using a validated liquid chromatography mass spectrometric method with a gradient elution method with water and acetonitrile as the mobile phase. Figure 4, 5, and 6 shows chromatograms obtained from selected water bodies identifying the respective signal peaks of the two medicines. As displayed in the key findings section, carbamazepine was detected in water samples obtained from Norris Canal and Beara Lake. Diazepam was detected in all 3 sampling sites. The highest carbamazepine concentration was detected in Norris Canal, which is 1.28 micrograms per liter. The highest concentration of diazepam was reported from the Beara Lake water sample, which is 0.70 micrograms per liter. All drug concentrations detected were above 0.1 micrograms per liter. When it comes to possible reasons for these findings, contamination with human excreta and disposal of pharmaceuticals from the surrounded hospitals, factories, and households may be the reasons for the presence of diazepam and carbamazepine in those water samples. In conclusion, these study results indicate the level of contamination of the water bodies tested with the studied pharmaceuticals and need for further studies on other pharmaceutical agents. Especially, presence of diazepam in the drinking water sample indicate the possible contaminations from other pharmaceuticals as well. Presence of pharmaceuticals in drinking water is a major concern because it acts as a direct route of entry to human bodies. The results obtained in this study can be used in the environmental risk assessments and necessary action on correct disposing of pharmaceutical agents in the country. The analytical method developed and validated can be further improved to detect other pharmaceutical residues also. Thank you very much.
Thank you very much, Bhavani. Now the paper is open for questions. Anybody who wants to send in questions can send in through the chat, and we will relay the message. So I'll start off the questions, Bhavani. Now you have found significant residues of these compounds in the drinking water. Have you taken the steps to notify the responsible authorities, or what are the things that you have done after your research? Ms. Vijay Singh, I hope you heard my question. After the research, what are the steps you have done to notify the authorities of your findings? Are you planning to publish?
I haven't contacted any authority because we have to improve this study to further steps because these samples, basically this study was on validation of analytical method. A major part of this study was to validate accurate, precise, and reliable method to identify pharmaceutical residues in water. Then to say, like Bear Lake water sample contain this much of, we have to improve this research by doing several samples. This study results were only for 3 samples. We have to take several samples for publication.
Thank you, Ms. Vijay Singh. And there's one more question from Dr. Roshini. Are there any special reasons to study carbamazepine or diazepam? Why not other commonly used drugs?
Because during literature survey, I found many adverse effects, both for ecosystem stability and for both human adverse effects for human health from these medicines. Therefore, I may choose these 2 drugs as my studied drugs. And of course, when considering the concentration of analytes to be present in the water samples, we have to select pharmaceuticals with higher possibility of present in the water sample. And of course, carbamazepine and medicine included in the essential medicines list. And the dosage is high for both of these drugs. So I selected these drugs for my study.
Thank you. Thank you very much, Ms. Vijay Singh. I think in the interest of time, we'll have to now move on. And Dr. Rahim has indicated to us that he will be joining online. However, since the connectivity issues are there, we are playing a pre-recorded presentation, but Dr. Rahim is available online for questions.
Good afternoon, everyone. Our study title is Starting Antithyroid Drugs Immediately After the Radioactive Iodine Therapy, Affecting the Therapeutic Outcome Among Thyrotoxic Patients. You're aware that the definitive treatment for thyrotoxicosis is surgery and radioactive iodine therapy. The outcome of radioactive iodine therapy can be affected by many factors, but the concurrent usage of antithyroid drugs affect the outcome very severely among these patients. The objective of the study to evaluate the outcome of radioiodine therapy with antithyroid drugs, which started immediately after the radioactive iodine therapy in hyperthyroid patients. This was a prospective follow-up study, and it was done among 57 thyrotoxic patients, and all these patients were referred by specialists for radioactive iodine therapy. A thyroid imaging was done using the technetium scan to confirm the etiology among these patients, and after confirming the etiology and the thyroid uptake, a 10 millicurie of radioactive iodine was given to these patients. After giving the radioactive iodine, all these patients were followed up for 6 months to confirm or to assess the outcome of radioactive iodine therapy. The outcome was assessed by the thyroid function test and the clinical features. All these patients were obtained informed written consent, and the ethical clearance was taken from the Ethics Review Committee Faculty of Medicine, University of Peradeniya, and the data was analyzed using the SPSS version 25. The study included 57 patients, and the mean age of the population was 52.12 years. There were 40 Graves' disease patients, which was around 70% of the study population, and 17 toxic multinodular goiter patients, which was around 30% of the study population. Among this population, 14%, around 8 patients were started on early carbimazole within 2 weeks from radioactive iodine therapy, and among them, 4 patients had therapeutic failure at the end of 6 months, which was 50% of the population which was started on early carbimazole. Among the population which was not started on the carbimazole or not on any other antithyroid drugs, the 49 patients, only 5 patients, which was around 10.2% of that population, had therapeutic failure. The comparison between these two groups showed that a significant difference. If the patients had started on early carbimazole, they had therapeutic failure. The likelihood ratio was 11.941 and the p-value was 0.003. So in conclusion, the therapeutic failure for radioactive iodine therapy was significantly high among thyrotoxic patients if they are started on early antithyroid drugs after radioactive iodine therapy. And the underlying reasons for this phenomena, the radiosensitivity of the thyroid cell is increased by the antithyroid drugs. So if the radiosensitivity is increased, the therapeutic effect of the radioactive iodine therapy will be reduced. And further, the effect of radioactive iodine therapy mainly depends on the production of free oxygen radicals. The free oxygen radical production depends on the thyroid peroxidase enzyme. This enzyme is inhibited by the antithyroid drugs. So the production of free oxygen radicals at the cellular level also reduced if antithyroid drugs are given with radioactive iodine therapy. And also the T-half of the radioactive iodine is reduced by antithyroid drugs. So all these mechanisms contribute to the reduced efficacy of radioactive iodine therapy, and as the end, more patients develop therapeutic failure. To overcome this effect, all the patients who are given radioactive iodine therapy for thyrotoxicosis are advised not to take antithyroid drugs for 6 weeks from radioactive iodine therapy. Thank you.
Thank you very much, Dr. Rahim, for that interesting presentation. The paper is now open for discussion, but I will ask one question first. How does your findings compare with those from international research? Has this been replicated elsewhere?
Yeah, there are several studies, and they have found the same outcome. There is therapeutic failure if they give the antithyroid drugs with radioiodine therapy immediately after radioiodine therapy.
Thank you very much, Dr. Rahim. We can have one more question in the interest of time. We'll have to move on. You can type and send in the chat. I noticed that some participants have already sent in questions for the previous presentation. I'm sure the previous presenter is still online, and so the question is visible. So you can reply to those participants with your reply to that. But we cannot entertain questions at the moment. So if further questions are absent for this presentation, I would like to move on to presentation C. Thank you very much, Dr. Rahim.
Thank you.
Poster presentation 3 is titled Key Determinants of Rational Use of Methylphenidate in Children with Attention Deficit Hyperactive Disorder, ADHD, in a tertiary healthcare center in Sri Lanka. The paper is authored by Mugunthan S., Sri Ranganathan S., Seneviratna S., and Dayabandara M. The paper is going to be presented by Mugunthan S., who is from the Lady Ridgeway Hospital, Colombo. Over to you, Dr. Mugunthan.
Good afternoon, everyone. Thank you for your kind introduction, sir. Good afternoon, everyone. I'm Sanjita Mugundan, Medical Officer attached to Child Psychiatry Unit LRH. Here is to present the study titled Key Determinants of Rational Use of Methylphenidate in Children with Attention Deficit Hyperactivity Disorder, ADHD, in a tertiary healthcare center in Sri Lanka. Drug utilization studies investigate rational use of medicine and show more than 50% of all medicines are used irrationally. Whole aim of this study is to document the issues related to children of varying age being treated with single-strength tablet form methylphenidate for an important child psychiatric disorder called ADHD, and also to describe common adverse effects in this population. This cross-sectional descriptive study was conducted at Child Psychiatry Units LRH in 2019. 108 children with ADHD aged 5 to 14 years were recruited, and data was collected mainly from interviewer-administered questionnaire and analyzed using SPSS software. Now let's move into results part. Here I will point out only main results. Now I am going to describe the pattern of practice in the study population in 3 stages: prescribing, dispensing, and administering. If we take prescribing factors, all the children were prescribed tablet form of methylphenidate with the dose range of 5 mg to 20 mg per day. Majority were given twice daily dose. All the parents were given either verbal or written form or both methods of direction of usage of this drug by prescribers. Here 98% received verbal and 50% received written form. When we consider dispensing factors, 94% of prescriptions were dispensed from hospital pharmacy, but hospital pharmacy never did segmentation of them. Dispensers gave direction of usage to the parents verbally to 51% and in written to 75%. Let me talk about administering factors. Out of 108, 96 parents, that is 89%, manipulated the tablet. Here, the splitting was the main method to get the prescribed dose, and to split 61% of them used hand, as depicted in Figure 1. Here we can see a number of parents of children with ADHD who manipulated the methylphenidate. Splitting was the main method. And 21.3 administered incorrect prescribed dose, and it is mainly due to difficulty in splitting the tablet, as shown in Table 1. Here in the Table 1, we can see the reasons for administering the incorrect dose. Here, 78.7% of parents administered correct dose, and the remaining 21.3% did not do so. The reason was mainly due to difficulty in splitting the tablet. Here we can see see the available 10 milligram strength tablet for methylphenidate, which has only one scoreline. So it's very difficult to split the tablet for the parents. And 30.6% were not administered the correct frequency. It is mainly due to fear of side effects. If we look into the adverse effects of this drug, 31% of children had poor weight gain, and it was mainly observed during the first year of treatment, as shown in figure 3. This bar graph shows 23 children had poor weight gain during the first year of treatment, and thereafter during 1 to 5 years duration, only 11 children had. Thereafter, when we take more than 5 years, none of them had poor weight gain. By this limited study, I can say irrational use of methylphenidate in children with ADHD at LRH appears to be due to non-availability of different pediatric strengths, formulations, and fear of adverse effects among the parents. Future work should be done with statistically calculated sample size to support this study, and possible intervention should be done to make sure the availability of pediatric strengths and formulation. These are some references of this study. Finally, I would like to thank Director LRH, staff, study participants, and their parents or caretakers for their support, and organizers of SLCAPT session to give this opportunity to present the study. Thank you very much.
The paper is now open for questions. I will start off by asking a question. You mentioned that the sample size was 108, which I presume is a convenient sample, and you highlighted the need for a larger scale study. Any idea what sort of a large sample you are referring to and whether it is feasible to recruit in Sri Lanka?
Yes, sir. It should be actually it should be done with the statistically calculated sample size. I could not do so because if the study was done as part of my MSc Clinical Pharmacology and Therapeutics program, so during the stipulated time, I had to submit the dissertation, and I could be able to collect the samples during 5 months duration. So I selected consecutive sample of 108 children, and really it's difficult because methylphenidate is prescribed by the child psychiatrist only, and it's available in the tertiary healthcare center. So methylphenidate is not prescribed from the other hospital. If I have to take sample from other hospital, we have to go on the other hospital with the child psychiatrist. So I could able to select during the timeline only this sample size.
So what you can do is, if you identify the primary outcome, you can calculate back from the sample size you have obtained and actually look at the power of your study. That is something that you may be interested in doing. There's one more question from Dr. M. Roshini. Was there a significant association with adverse effects and incorrect dose?
Sorry, incorrect dose?
Was there a significant association with adverse effects and incorrect dose?
Yeah. Incorrect dose. When we give the incorrect dose, the disease symptoms may not disappear. So untreated or partially treated attention deficit hyperacuity disorder children, later on it can be a major impact on their learning as well as the attention, and these children can go can have the behavioral disorders, and they can go for the abuse, and this is a major burden for the society and the government. So it should be treated properly. Disease should be treated properly, but I can't say only the treatment is methylphenidate. We have to give the behavioral management as well. But methylphenidate should be given properly, and disease should be treated in a proper manner.
Dr. Mugundan, there's one more question. Are the side effects noted different from other studies or the same?
The studies also say same. They observe the poor weight gain. That is the main adverse effects of this methyl medicine, and they also observe during the initial part of the treatment. Thereafter, with the time, It's very less poor gain and poor height gain all are less during with the time of treatment, duration of treatment. Other studies also support. Most of the results are supportive with the other studies done in other centers and abroad.
Thank you very much, Dr. Mohandan. And in the interest of time, I think now we'll have to move on. The final poster presentation for the day is titled Knowledge and Adherence on Oral Anti-Cancer Medications of Patients Attending 3 Selected Cancer Clinics in Sri Lanka. The authors are Pushpakumara S., Vimalasena L., Ariyaratna K., Karunaratna I, Manapiruma U, and Pallegedara A. The paper is going to be presented by Mr. Sampath Pushpakumara, who is from the Teaching Hospital, Kurunagala. Over to you, Mr. Sampath.
Good afternoon, dear ladies and gentlemen. Pharmacist in Teaching Hospital, Kurunagala. I present my study title, Knowledge and Adherence on Oral Anti-Cancer Medications of Patients Attending 3 Selected Cancer Clinics in Sri Lanka. As we all know, cancer is one of the leading cause of death worldwide. Oral drug administration is convenient and easy to use. Therefore, most patients prefer to have oral anti-cancer drug therapy compared to currently administered therapies. Patients' knowledge about medications is a key factor affecting how medicines are taken correctly and adherence to therapy. The general objective of the study was to determine the knowledge and adherence regarding use of oral anti-cancer medication among cancer patients attending cancer clinic of 3 government hospitals in Sri Lanka. The study was descriptive cross-sectional study. Data were collected in National Cancer Institute Maharagama, Teaching Hospital Kurunagala, and General Hospital Badulla from April to August in 2019. Patients who were on at least one oral anti-cancer medicine for more than 3 months and aged more than 18 years were included in the study. Ethical approval was taken from ERC, Faculty of Medicine, Colombo, and patients' consent was taken prior to the data collection. Patients' knowledge on anti-cancer drugs was assessed by an interviewer-administrated questionnaire. It included patients' knowledge on medicines taken, dose, dosage regimen, storage, side effects, and missed dose. Patients' knowledge on medication name, dose, frequency, and with regards to meals was given weighted scores to give a cumulative value of 60. Patients were categorized as those with poor and good knowledge. The adherence was assessed using 2 methods. Those were medication diary filled by patients for 1 month and by calculating the medication poison ratio MPR as given in the poster. Now I present our results. 345 patients participated into our study, 115 from each hospital. Most patients were on treatment for breast cancer given in figure 1. As given in table 1, almost all patients knew when to take the medicine and the dosage form. 1/3 of the patients did not know the name of the medicine, but 90% knew how to take their medication regimen correctly. We did binary logistic regression analysis to find what factors affect good knowledge and taking that regimen correctly. According to the table 2, patients with secondary education having children and higher monthly income were more likely to have good knowledge. The patients who reported being educated by doctor and pharmacists, patients with secondary education and patients with children were more likely to know their medication regimen correctly according to table 3. Approximately 94% patients were adherence to medication regimen determined by the NPR and the patient's diaries. We could not find any association with adherence and patient's factors. I draw attention to the finding the patients educated by doctors and pharmacists had shown better knowledge and highlighting the importance of patients counseling. Level of education and monthly income both affected the patient's knowledge on medicines, similar to the study done in Sri Lanka on patients with cardiovascular diseases, which made similar conclusions. The conclusions of this study are: majority of the patients have good knowledge to take medicine regimen correctly. Adherence to oral cancer medication is high in patients attending the cancer clinic in our study. Patients with higher education, high monthly income, and patients with children were more likely to have good knowledge on their anti-cancer medicines. Provision of education by doctors and pharmacists enable patients to take their medicine regimen correctly. Finally, I would thank to all who supported to successfully conduct this study. Thank you.
Thank you very much, Sampath. Now the paper is open for questions.
Hello, can you hear me? There is a question.
Yes.
How did you select these 3 hospitals?
I got
Why? Not how, why?
There is 3 hospitals. They are very major patients attend to the hospital for the cancer treatment, and there are different regions from the country.
How is it that?
Why
Why Badula will they get different patients? What is it?
It's an upcountry town.
There is no other hospitals which give oral anti-cancer medicine in upcountry?
But available. We are doing research and we selected this 3 hospital because of our 3 members working in this 3 hospital, and we are very easy to take.
Yeah, that is the reason I was expecting that to be presented in the methods. Then of course this question will not be coming. The second thing is that how did you do the knowledge question here? How did you know that the knowledge can be classified as poor and good?
Yes, madam. According to the based an article published by Pereira et al., weighted score was given like this: medicine name 20, dose 20, frequency 10, and according to the means before after 10 marks. And we got less than 40 poor knowledge, and equal or greater than 40 good knowledge.
Didn't you check about knowledge about warning signs of adverse effects?
No, madam.
In the absence of further questions, I would like to thank Mr. Sampath. So, ladies and gentlemen, that brings us to the end of the post-presentation session. I would like to thank all the 4 presenters for being online on time and sticking to the time stipulated for them. And also, I would like to thank the 2 judges who joined us online, Professor Amari Viratna and Dr. Roshini Murugapille. So, with that, we conclude the session on poster presentations. And at 3 o'clock, we'll be starting the oral presentation sessions too. So do join us at that time. Thank you very much. Good afternoon, ladies and gentlemen. We are back again now live for the oral presentation sessions. To chair the sessions, I would like to invite Professor Sharini Sriranganathan, Professor in Pharmacology, University of Colombo, who is also the Secretary of the SLACPT, joined by Dr. Sujivani Kurukulusurya, Senior Lecturer in Pharmacology, University of Kelaniya. Over to you, Madam.
Okay. Yeah, good evening. We are about to start the oral presentations, and the first presentation is on pre-intern perception regarding anaphylaxis. What you have to remember is all presenters get 8 minutes for the presentation and 2 minutes for the questions. And the authors of this paper are Vettasinghe I, Thenuvara P, Jayawardena P, and Vijay Konsian, all from the Department of Pharmacology, Faculty of Medical Sciences, University of Sri Jayawardenepura. Over to you, Dr. Vettasinghe.
Good afternoon. I'm Dr. Indika Vettasinghe, representing the Department of Pharmacology, University of Sri Jayawardenepura. And I'm here to talk about our study titled Pre-Intern's Perception Regarding Anaphylaxis, a study which was conducted among pre-intern medical graduates from a state university. So are these pre-intern medical graduates ready to handle anaphylaxis? So as we all know, anaphylaxis is a medical emergency. And early recognition and appropriate management is crucial in minimizing the morbidity and mortality. And these pre-interns will soon become the first contact doctors who will be primarily responsible for diagnosing and managing anaphylaxis. They would be the house officers in the state hospitals. So the general objective of our research was to determine how these pre-intern medical graduates who qualified with MBBS perceived anaphylaxis. We also assessed their knowledge regarding the triggers of anaphylaxis, the knowledge regarding the diagnosis and management of anaphylaxis, and we also looked into the level of self-confidence with regard to diagnosis and management. So it was a cross-sectional study. It included MBBS graduates of a selected university in Sri Lanka. Consecutive sampling was used and data collection was done using a self-administered questionnaire. The questionnaire consisted of case scenarios, true-false questions, single-answer MCQs, and open-ended questions. So here is the example of the case scenarios, which was used for the diagnosis, to assess the knowledge regarding the diagnosis of anaphylaxis. And this is the case scenario. These are the questions regarding the management of anaphylaxis. The study population was of 168 participants with a response rate of 84.5%, and 60% of the population were females. So moving to the results, only 14.8% of the population identified all stated anaphylactic triggers. And knowledge regarding the allergens that are colored in yellow, which include soy, green leaves, green grams, chickpeas, or dill sesame, the knowledge regarding that you can see is relatively poor. I would like to draw your attention to platelet transfusions. So 78% have answered that platelet transfusions can cause anaphylaxis, which means that more than 20% of the population are under the impression that platelet transfusions do not cause anaphylaxis. So this is again an area of concern because it is the house officers that are primarily responsible for conducting these platelet transfusions in the ward setting. Surprisingly, in fact, very surprisingly, 17% of the population did not know that there is a set criteria to diagnose anaphylaxis. Almost 16% did not know that anaphylaxis can occur without skin manifestations. And 20% of the population did not know that anaphylaxis can occur without hypotension. Nobody answered all 10 case scenarios correctly. And questions for case scenarios 4 and 9 were poorly answered. So I would like to read out question 4 and 9. So question 4 goes as, a patient with a known history of allergy to prawns develops vomiting, diarrhea, and hypotension soon after eating sarana, which is a green leafy vegetable. So for some reason, more than 40% of the population went with allergy, but this is actually an anaphylaxis because two systems are involved. Similarly, in question 9, it goes as a patient with a known history of allergy to ibuprofen develops acute onset wheezing with no other signs or symptoms after taking diclofenac sodium. So more than 60% of the population went with anaphylaxis for some reason, but here again, it's an allergy. So the mean score for the case diagnosis was 6.64 out of 10, with the females faring slightly better than the males. And there was a clear relationship between the final MBBS results and our score. So better the results in the final MBBS or higher the class, better the score in our study. But of course, there was no statistical significance in that. 97.2% of the population correctly answered that the first drug to administer in anaphylaxis is 1 in 1000 adrenaline. However, only 78% of the population knew the correct adult dose. And very surprisingly, only 40% of the population knew the correct pediatric dose of adrenaline. This was quite unexpected. So moving on, 28% of the population was under the wrong impression. 28% of the population was under the wrong impression that the best site to administer intramuscular adrenaline is the deltoid muscle. 34% of the population did not know how to position a patient during anaphylaxis. And 35% of the population did not know that follow-up care is needed on discharge after a patient recovers from anaphylaxis. This again is surprising and a bit troublesome, but because it's usually the duty of the house officer to write the diagnosis and discharge card and arrange follow-up in most situations. The mean score for the anaphylaxis management was 16.2 out of 20, again with the females faring slightly better than the males. Again, there was a clear relationship between the final MBBS results category and the score in our study. So better the class in the final MBBS, better the score in our study. And this time there was a statistical significance. Moving on to the self-appraisal, 72% of the population stated that they were confident in diagnosing anaphylaxis, but only 51% were confident in managing anaphylaxis. And the main cause for the lack of self-confidence was the absence of hands-on experience in managing anaphylaxis, even though they had seen the management of anaphylaxis. And there was no statistical significant relationship between the final MBBS result score and the level of self-confidence. So interestingly, majority of the population, 73.2% of the population and 79.6% of the population have stated that they have gained their knowledge regarding anaphylaxis from the third year clinical appointments and the immunology lectures, which is a higher percentage when compared with the final year clinical appointments. Similarly, majority of the population have stated that they have gained their skills, acquired their skills from the third year clinical appointments, a high percentage when compared to the final year clinical appointments. So just to recap, 20% of the population did not know that anaphylaxis can occur without hypotension. 16% did not know that anaphylaxis can occur without skin manifestations. Only 22% knew the correct adult dose of adrenaline, and only 60% knew the correct, and 60% of the population did not know the correct pediatric dose of adrenaline. And 35% of the population did not know that follow-up care is necessary in a patient who has recovered from anaphylaxis. So even though the knowledge perception of these participants was not optimal, when compared with other studies, they have fared fairly better. So for example, here when we consider the knowledge regarding adrenaline, the participants of our study have fared far better than participants of previous studies done among first contact doctors. So these are our conclusions. And I would like to recommend the following. One, we would like to conduct an island-wide study involving all the universities in the country to see if there's a difference in the knowledge and the perception among the pre-intern medical graduates. And if there are any differences, we need to see the cause and rectify it. So actually we have moved into this area and we have collected and processed data from 2 other universities, and the results are pretty interesting. Secondly, we would like to recommend a study done on post-intern medical graduates to see if the hands-on experience they have had during internship would actually increase their level of self-confidence. Because if you could recall, only 50% of the population were confident in managing anaphylaxis, and the main cause for the lack of self-confidence was the lack of hands-on experience. And finally, I would like to finally, our study has shown some striking weak points in the students' knowledge, very surprising and striking weak points. So we would recommend the academic staff to look into the matter and make changes to the curriculum to strengthen these unexpected weak points. So that concludes my presentation.
Thank you,
Thank you.
Dr. Wittasinghe. Any questions online or?
Yeah, can I ask a question, Sujivani?
So we had the question was to state the pediatric dose of adrenaline. We were expecting an answer of so the answer had a blank with milligrams per kilogram. So we were expecting 0.01 milligrams per kilogram, an answer of that category. Yes, madam. Yes, madam. No, so I would show the question here. We were expecting the answer in milligrams per kilogram. So it's 0.01 milligrams per kilogram as a it's the dose per weight.
Yeah, no, I
Yeah.
know, but on this at the same time, when you ask pediatric, people would not have realized. I'm not saying that your study is wrong, but what I mean is that would have been a bit too wide,
Okay.
not very, very clear for a pre-intern to be able to do that, because to know the dose, because
Yeah.
again, there are different doses for the different age groups in pediatrics.
Yes, madam.
In adults, it is fairly simple, but
Yeah.
in pediatric. So and rather for them, trying to remember that, it would be best to ask whether they check some, whether there's a formulary or whatever where they can get the correct dose, because they might end up giving wrong doses.
Correct, madam. Right.
From pediatric point of view.
Thank you, Dr. Wittasinghe, for that interesting presentation.
Okay. Thank you.
And we go on to oral presentation number 2. The impact of selected clinical pharmacy services on medication safety and prescription costs among a cohort of patients attending a primary healthcare setting in Sri Lanka. So the authors here are A. Amarasinghe, B. Herath, S. Senadira, S. Samaranayaka, and N. Samaranayaka. So the paper will be presented by Dr. A. Amarasinghe.
Good evening, everyone. I'm Anushanga Amarasinghe from the Faculty of Allied Health Sciences from University of Chidadhanpura. I'm here to present our abstract for you all. And our study was the impact of selected clinical pharmacy services on medication safety and prescription cost among a cohort of patients attending a primary healthcare setting in Sri Lanka. As we all know, patient safety is the major concern of our healthcare system. And in the worldwide, we have known that clinical pharmacy services have shown to improve the quality use of medicines in patients. In Sri Lanka, there are some research has been done in the government sector, tertiary care level about these clinical pharmacy services. But however, up to my knowledge, none of them have been done in a primary healthcare level and on the prescription cost. So we try to assess the impact of these impact of selected clinical pharmacy services on medication safety and prescription cost. While doing that, we try to assess the prevalence of drug-related problems during taking a complete medication history, during medical reconciliation and medication reviewing. And then we determine the percentage of prescribers' acceptance of these drug-related problems identified during these stages. Then next, we try to assess the impact of medication reviewing and reconciliation on the prescription cost. Our design was a descriptive cross-sectional study done in a primary healthcare medical center affiliated to a state university in Colombo. And we included all the patients who visited the setting, who were 18 years of age or above, and who attended the medical clinic of the healthcare center and prescribed with at least one medication in the latest prescription. And we excluded the patients who did not possess any written evidences like past prescriptions and past health records. And we recruited the patients attending the setting from October 1st, 2019 to December 1st, 2019. And we selected the patients by a systematic random sampling method. And we use structured interview patients to take the medication history of patients and medication reconciliation and reviewing as our study instruments. And the ethics approval was taken prior to the study. And this is our study process. We first obtained the informed consent from patients as well as from the prescribers. And we took a complete medication history, including their presenting complaints, their social history, medication history, surgical history, their allergies, and their uh, their medications they take. And we assess their adherence to medication using the Morisky medication adherence assessment. Then we reconcile their latest prescriptions with against their indications and long-term medications they take. Then we review their prescription for the appropriateness of medicines using BNF 75th edition, Oxford Handbook Clinical Pharmacy 3rd edition, Australian Medicines Handbook, and the modified stop-start criteria for Sri Lanka. And we use Medscape interaction finder to check whether there are any interactions in the prescription. And we summarize those drug-related problems we identified during stages and make some case summaries. Then we circulated these case summaries among a panel of prescribers in our healthcare setting. And then we assess the impact of medication review and reconciliation on the prescription cost. For that, we first calculate the current prescription cost, which is the original prescription cost using a medicine price list obtained from the State Pharmaceutical Corporation on a specified date. Then another prescription cost, which is new prescription cost 1, calculated after the consideration of proposed clinical pharmacy interventions by the researchers. Then another prescription cost, which is new prescription cost 2, by recalculating the cost after the acceptance of 3 prescribers. And this is how we calculated our prescription cost. And this is our recruitment of patients. There were 150 patients who visited the healthcare setting at that specified time period, but we could recruited only 51 patients who fulfilled our inclusion criteria. We have to exclude 99 because some of them were not visiting the medical clinic and some of them didn't have any written evidences. So we have to exclude 99 patients. And according to the results, most of the patients who visited the healthcare setting were women, and most of them, about more than 50%, was above 60 years old. And all the patients paid for their medicines out of pocket, so they have no insurance. And more than major amount, more than 50%, 58.8% patients have said that they have financial difficulties in purchasing their medicines. And during taking medication history, we found out 12 drug-related problems, and 5 of them were self-prescribing medicines. And we found out major amount of patients have less adherence to medication during this medication adherence scale. And we only found out 2 reconciliation drug-related problems during the reconciliation stage. And major amount of drug-related problems were found out during the medication reviewing, including wrong indication, wrong strength, wrong frequency. Altogether, it was 88. And this showed the summary of drug-related problems we found out during those stages. And this is the acceptance of prescribers of our drug-related problems. We got 55.5% of overall acceptance for our drug-related problems from the prescribers. And this is our impact of clinical pharmacy services on the prescription cost. We managed to reduce 45.2% of the prescription cost by the proposed changes by the researchers, but it was only 2.5% after the prescriber acceptance. And after our study, we would like to say that there's a positive impact of clinical pharmacy services on the medication safety and as well as the prescription cost when it take by case. And we can give a lot of benefit to the patient by implementing a clinical pharmacy services for the primary healthcare setting. And we found out that the clinical pharmacists and the prescribers should have a set of agreed treatment guidelines to follow to give the maximum effect and to give a minimum cost to the patient when when the patients are visiting to a primary healthcare setting, because primary healthcare setting, you have to pay for your bills, pay for your medicines, not like the tertiary care level. So we have to give the maximum therapeutic effect with the low cost. So that is our research, and we found out that clinical pharmacy services can do it. And these are our references. And thank you for listening, and thank you for giving this chance to us. Thank you.
Okay, thank you, Dr. Amarasinghe, for sticking to time. Now the presentation is open for questions here.
There's a question in the chat. Before that, I want to ask a simple question. What is the statement about primary healthcare settings the patients have to pay? Is it specific to your hospital, or is it specific to the entire Sri Lanka?
Is it specific to the entire Sri Lanka, madam?
I said all the primary healthcare settings, they have to pay for their medicines?
Yeah, they only give the prescription. They don't have any pharmacy services inside the healthcare setting, especially in our university. We did it in our university healthcare setting.
Specific to your hospital, but in the country, Professor Roy, if you enter place there, because I have done a study on preliminary healthcare units, their availability of antibiotics and all above 70% is also there. I think you are mistaken in your particular setting. I think they are paying.
Yeah, the particular setting, because
you said entire Sri Lanka, so
it can be implemented to the entire Sri Lanka, the services, but more.
No, everyone is confused with that question. That is it the primary healthcare setting in Sri Lanka? Are you claiming that the patients are paying for it?
No, it is for this study and this setting.
Thank you. There is a question here because it's from the chat. So, how was wrong indication determined? Stop-start criteria is only for all the adults, and because these are for family practice centers. So this is a question from the chat from one of the guests logged in. Did you understand the question?
Yes.
Yeah. Can you?
In our process, we gave the prescribers a special prescription where all the details are written, and the list of medicines were checked with the indication using those guidelines, BNF and clinical pharmacy handbooks. The indication was checked by that guidelines.
I hope the answer satisfied the person who questioned it. There's another question. What are the reasons for low prescriber acceptance of your changes?
Most of the places, the prescribers do not agree to change the brand name. But we were going through the guidelines and the price list obtained from the SPC, which was for the generic price. And most of the places, the brand name was not changed by the prescriber. But because we are going through a guideline, we have to give the generic price for the medicine. So that was the main issue with the prescriber acceptance.
Okay, thank you.
Okay, thank you.
Yeah, so oral presentation 3 is on patient-reported outcome measures to assess the effectiveness of inhaled medications in asthma. The authors are Y. Guruparan, G. Selvaratnam, Nadika Gunodana, Tiyahini S.N., and Sri Ranganathan S. The presenter is Y. Guruparan.
Thank you, Honorable Chairperson. Good afternoon, ladies and gentlemen. I am going to present my research on patient-reported outcome measure to assess the effectiveness of inhaled medications in the treatment of asthma. Asthma is one of the chronic conditions affecting all age groups worldwide. In Sri Lanka, among the non-communicable reported cases among adults, 1 in 6 being affected by asthma. Inhaled medications are the mainstay of treatment of asthma. Current trend in assessing the effectiveness of treatment of chronic condition is using patient-reported outcome measure, which is called as PROC. Patient-reported outcome measure is defined as any report of the status of the patient's health conditions that directly comes from the patient without interpretation of the patient response by a clinician or anyone else. Therefore, this study was designed with the objective of developing patient-reported outcome measure to assess the effectiveness of inhaled medications in the treatment of asthma. Now we will look into the methodology. According to Food and Drug Administration guidelines, patient-reported outcome measure was developed in 3 steps. They are item generation, item reduction, and psychometric evaluation. Item generation is the process of establishing the items in an instrument. Item reduction is a method to eliminate the items which are not suitable for the instrument. Psychometric evaluation was done to assess the reliability, phase, and content validity. In this study, items were generated through focus group discussion. Item reduction was done by Delphi technique and exploratory fact analysis. Exploratory fact analysis is a statistical method used to reduce the number of items, group the similar items under different categories, and determine the internal consistency. Both qualitative and quantitative study designs were used. Items were generated through focus group discussions at medical clinics of Teaching Hospital Jaffna. Item reduction was done by Delphi technique among experts, and experts were selected from Faculty of Medicine Jaffna, Faculty of Medicine Colombo, and Teaching Hospital Jaffna. Exploratory fact analysis was carried out at medical clinics of Bayes Hospital, Tellibre. Focus group discussions were conducted from February to April 2019. 2 rounds of online Delphi survey were conducted from May to July 2019. Exploratory fact analysis was carried out in August and September 2019. Definition of asthma by Global Initiative for Asthma Treatment Guidelines was used as the case definition for patients with asthma in this study. Focus group discussions were conducted among adult patients with asthma on inhaled medications for at least 3 months and attending medical clinics at Teaching Hospital Jaffna. Patients with chronic obstructive pulmonary disease, bronchiectasis, and congestive cardiac failure were excluded. Delphi technique was conducted among respiratory physicians, general physicians, clinical pharmacologists, general practitioners, and senior medical officers who are working in medical units for 5 years or more. Exploratory fact analysis, same definition as focus group discussion was used for study population in a different study setting. Number of focus group discussions and number of participants for focus group discussion were decided as 6 and 10 respectively. Purposive sampling was used to recruit participants with the aim of achieving maximum variation. Number of participants for Delphi technique was 10. Exploratory fact analysis, 200 participants were recruited consecutively. Ethical and administrative approvals were obtained from relevant authorities. Since development of patient-reported outcome measure is a sequential process, rest of the methodology is presented together with respective results of each step. This figure shows the methodology of prompt development. First, we look into item generation. Principal investigator conducted 6 focus group discussions under 3 categories based on the educational level of the participants. Number of participants per group varied from 6 to 10. Information gathered from the focus group discussion was transcribed into verbatim and thematic analysis was done. Items generated from thematic analysis were reviewed independently by principal investigator and 2 clinical pharmacologists for appropriateness in assessing effectiveness, duplications, and applicability to all patients with asthma. Number of items generated through thematic analysis was 24 and number of items selected through subsequent independent review was 10. First step in item reduction was Delphi technique with 2 rounds of online survey. Online survey form for the round 1 was developed with 10 items that were generated from focus group discussion. In the round 1, all the 10 items were scored above the cutoff value and were selected for round 2 of Delphi survey. In the round 2, same experts were used to get responses. Out of 10, 9 items had the score above 4 with 80% consensus among experts. These items were subjected for exploratory factor analysis. The 9 retained items were converted into statements with 5-point Likert scale and used as interviewer-administered questionnaire for the data collection of exploratory factor analysis. Inter-item correlation and factor extractions were done using SPSS. correlation coefficient is above 0.3. Fact extraction was done using Kaiser criteria. Out of 9 items, 8 had the correlation coefficient above 3 were categorized under 2 factors. In exploratory fact analysis, based on similarities in items are grouped under different categories. These categories are called as factors. These 8 items were taken for the PRUM to assess the effectiveness of inhaled medications. This figure shows how the final 8 items of the PRUM were derived from initial 24 items through multiple steps. This table summarizes the 8 items that are categorized under 2 factors. Factor 1 items are related to exacerbation and activity. Factor 2 items are related to symptoms. Psychometric evaluation. Data of exploratory fact analysis used to assess the reliability of generated items using Cronbach alpha. Acceptable value for Cronbach alpha ranging from 0.7 to 0.95. Cronbach alpha for generated items of this study was 0.904. Phase and content validity were assessed by experts during Delphi survey by assessing the clarity of the statements. This is the developed PRUM tool. I conclude that using this multiple step methodology, we were able to develop PRUM that would be useful to assess the effectiveness of inhaled medications in adult patients with asthma in the local context. However, this tool has to be subjected to criterion validity and application in large population in order to confirm its actual usefulness, which I am currently doing. We would like to thank the following people. Thank you.
Thank you, Dr. Gruparan. Any questions?
Yeah, there is one question. Can you repeat?
Yes. Yes, ma'am.
Yeah, sorry. Good PROMs. How do we do the PROM? How do the PROMs correlate with the parameters that given in the various guidelines to assess control? These are what clinicians use.
I couldn't get.
What your response? Okay, shall I repeat? Yeah.
Yes.
Good PROMs. How do the PROMs correlate with the parameters that given in various guidelines to assess control? These are what clinicians use. That's not exact, it's like an observation. I think they want your opinion on that.
Clinicians are used in the Global Initiative Asthma Control Guidelines. This one I used to assess the effectiveness of inhaled medication. They usually use the Global Initiative for Asthma Treatment Guidelines, Asthma Control.
Okay, thank you, Dr. Guruparan.
Thank
Any
you.
other questions?
Okay, so in the absence of any more questions, we will move on to the next presentation, that is the oral presentation 4. The title of the presentation is Major Drivers of Pharmaceutical Cost in State Sector Healthcare Institution of Sri Lanka. The researchers are Yasaratna KWGK, Gunasegara ADM, Pannapitia PWC, Vaniarachi LC, and Fernando Pille BMR. They are from Faculty of Medicine, General Sir John Kotalawala Defence University, Ratmalana, Sri Lanka, and the Ministry of Health, Sri Lanka, Medical Supplies Division, Sri Lanka. The paper would be presented by Gunasegara ADM. Over to you.
Thank you, Madam Chairperson. Ladies and gentlemen, good afternoon. I'm Dhanushi Gunasekara, and I would like to present our study, Major Drivers of Pharmaceutical Costs in State Sector Healthcare Institutions of Sri Lanka. This is the outline of my presentation. To start off with the introduction, Sri Lanka is committed for free health coverage, but the health and the pharmaceutical budgets have increased through the years, and it is important to spend pharmaceutical budgets wisely to ensure the availability of essential medicines. ABC analysis is one of the most widely used techniques to determine whether the pharmaceutical budget is spent appropriately. It measures the degree to which actual drug consumption reflects public health needs and helps identify irrational drug use and overuse. ABC analysis using the Pareto principle classifies items in the inventory into three groups, namely A, B, and C. Group A represents 70 to 80% of the total budget value and includes about 10 to 20% of items which are large volume or high unit cost items, which results in the high cost. And Group B includes 15 to 20% of the budget value, and Group C includes only 10% of the 5 to 10% of the budget value, and represents 60 to 80% of the majority inventory items. Group A is important because greatest potential for savings and greatest potential for identifying expensive medicines that are overused. The general objective was to identify the major cost drivers of pharmaceuticals in state sector healthcare institutions of Sri Lanka from 2014 to 2018, using the aggregated data from the Medical Supplies Division. Specific objectives were to analyze the aggregated data of pharmaceuticals using ABC analysis and to identify the major cost drivers. Moving on to the methodology, data on issues of medicines from 2014 to 2018 were extracted from the database of the Medical Supplies Division of the Ministry of Health. Unit cost and quantity of each item were recorded. The total monetary value of consumption and the percentage of total value represented by each medicine were calculated. And then the medicine list was rearranged by ranking the medicines in descending order according to the percentage of total value of consumption. Cumulative percentage of the total value for each medicine was calculated, and then the medicine list was categorized to A, B, and C. A included items accounting to 75% of the total value, B included 15% of the total value, and C included items accounting to the remaining 10%. Top 10 medicines in terms of total cost and unit cost were identified, and costs were expressed in Sri Lankan rupees. In our study, we found that the total expenditure for medicines had increased in about 1.8 folds from 2014 to 2018. Apart from that, the number of items in the top 25% of the total value had declined from 15 to 10 items by 2018. Further, if you look at the percentage of medicines in ABC groups, in Group A, which accounted to 75% of the total value, included about 15 to 17% of the total items, and Group B included 17 to 18% of the total items, as well as Group C, which included 65% of the total items. And both Group B and C had seen an increase in the total number of items from 2014 to 2018. If you look at the top 10 medicines in terms of total cost, some of the widely used medicines like sodium chloride was among the top 10, and also some of the biologic medicines which have high unit cost were also among the top 10 in if you look at 2014 to 2018. Further, if you look at the another widely used medicine, that is paracetamol, was among the top 10 from 2014 to 2017. Apart from that, there were a number of medicines used for NCD, like insulin for diabetes mellitus was among the top 10 in all 5 years. And among antibiotics, amoxicillin was one of the top 10 in 2014 and 2015. And in 2017 and 2018, we saw co-amoxiclav injection also among the top 10. In 2018, we also found that ferrous fumarate plus folic acid tablet combination was also in top 10. This was mainly due to the increased quantity and comparatively high unit cost to other ferrous salts, which resulted in the inclusion of ferrous fumarate plus folic acid in the top 10. If you look at the contribution of medicines for non-communicable diseases among the top 10, we can see that the medicines for neoplasms cost has gradually increased over the 5 years, as well as the medicines for other NCDs like diabetes and cardiovascular medicines among the top 10 in terms of total cost. If you look at the top 10 medicines in terms of unit cost, most of the medicines were specialized medicines. And if you look at 2018 medicines, the unit cost of these medicines as a percentage from the GDP per capita in 2018 ranged from 30 to 45%, which is considerably very high. Looking at the mortality and health statistics of Sri Lanka, the leading causes of hospital deaths in 2018, we can see that first two leading causes are ischemic heart disease and neoplasms, which align with our findings that pharmaceutical costs for these conditions are high. And even though the diseases of respiratory system is the fourth leading cause, we did not observe any items specifically treating these conditions among the top 10 in terms of unit cost. In conclusion, the main driver of cost in Group A was biologics by price. Medicines for non-communicable diseases, excluding cancer, became next due to the high volume of use with the increasing prevalence of NCDs. And steps taken to identify excess usage patterns and minimize irrational use, improving lifestyle management strategies for preventable NCDs, and also applying health technology assessment to inform decisions on funding for newer medicines can be helpful for future cost savings. These are some of my references. I would like to express my sincere gratitude to the President and the members of the Sri Lanka Association of Clinical Pharmacology and Therapeutics for giving me this opportunity to present today. And I would also like to thank all the authors of the study. Thank you.
Thank you, Dr. Gunasegara, for keeping on time. This paper is now open for discussion. So, because there are no questions from anyone, why do you think the medicines which are used for communicable diseases have not come on top?
It's interesting. I think even though it doesn't appear in the top 10, there were a number of antibiotics among the, let's say, top 30 of the cost. But it could be that I think the number of patients who are on treatment for these chronic conditions are quite high, that the usage is higher, even though antibiotics are also utilized. We only saw amoxicillin mainly in the top 10 because it's widely used in outpatient care also, most likely.
Because the communicable diseases are generally short duration of treatment, whereas the non-communicable diseases are, if you prescribe, will go for a longer duration. That is also possible, no?
Yes, yes.
Okay, in the absence of any question, let me thank you for your nice presentation. You may take your seat. So the next presenter, I think, is joining online. The title of the presentation is Determining the Quality of Extemporaneously Compounded Individual Unit Dose Powders of Furosemide and Propranolol used in pediatric patients and improving the method of compounding. The authors of these papers are Nisansala MSB, Ranasinghe EKDB, Thambavita D, and Mannaperuma U, and Department of Pharmacology, Faculty of Medicine, University of Colombo, Sri Lanka, and the paper would be presented by Nisansala MSB. You may proceed with your presentation. Did you unmute yourself, Nisansala? Our AV team, is there any problem? So she must not have unmuted. Do we need to call her? Can you see her? Can we see her? No, no. Must be students because Tambavita and Manaparama belongs to our department. Other two maybe students, madam. Students means pharmacy students. We can hear even though the volume is low. Someone is, this is Dr. Roshini from Betiklo. She is saying, we can hear even though the volume is low. So she must be continuing now.
Yes, but the slides are not changing, no? Just continuing the slides.
No, she has stopped now, madam. So now Roshini is telling she has stopped, madam. You want to call or you want me to move to the next one then? Next one? Huh? She want me to send to her? This one, sir. She is not Puddini Dansala. Yeah. Now screen is shared. We can't hear you. We can't hear Kila Manlaiva. And Chattikaliva. Hari. She is asking to continue from Sitara to everyone. She is asking to continue. Shall I say to stop for a while or? Sitara must be one of the participants. She must have called. All right. So now the press. I think it's right. Yeah, now she has to talk now. She need to share the screen and voice as well. She is sharing the screen now, Dr. Sajid. Please ask her to share the voice. I am asking. Please share the voice. Utpali should have been joined in, or she should be. Next, can we move to the next one? So, Ms. Nisansala, if you can hear me, that we are going to the next one, you can check the mistakes and come again after we finish the last presentation. So now the oral presentation 6, that's the title of the presentation is Adverse Effect of Long-Term Amiodarone Therapy, a single center cohort study in Sri Lanka. The authors are Disanayaka DMPK, Gunavardhana DS, Ranasinghe JGS, Varnasuriya WMSN, Dayaratna UHJP and Javardhana RT. All of them are from Cardiology Unit, National Hospital, Kandy. And the paper will be presented online by Dr. Disanayaka, DMPK. Dr. Disanayaka, it is over to you.
Yes, ma'am. Yes.
Slideshow.
Good evening, everybody. Can I hear me?
Yes, we can.
Yes. Good evening, everybody. I'm Dr.
Can you put to slideshow, Dr. Disanayaka?
Yes, ma'am. I have put it.
Slideshow.
Yes,
Yeah.
I have done it.
No, it didn't come. All right, now only.
All right.
Right.
Okay.
Right, start.
Right, ma'am. I'm Dr. DMPK Disanayaka, one of senior registrar in medicine, teaching hospital Peradeniya. Today, I'm going to discuss about a single-centered cohort study regarding adverse effects of long-term amidon therapy. These are my co-investigators. And this is my outline of discussion. And amiodarone is an effective anti-arrhythmic agent used for wide range of refractory tachyarrhythmias, including the lot of ventricular tachyarrhythmias and the several supraventricular tachycardias. Amiodarone was discovered in 1961 and FDA approval granted in 1985. There's a lag between 61 to 85 because this long lag is due to approval has not been given because of amiodarone has shown the lot of adverse reaction, especially the pulmonary fibrosis. So amiodarone is an iodinated benzofuran derivative with 2 atoms of iodine and shows wide spectrum anti-arrhythmic activity by blocking sodium, calcium, and repolarizing potassium channel. And it belongs to a class 3 anti-arrhythmic agent, but it has, interestingly, it has a electrophysiological characteristic of all 4 classes of anti-arrhythmic agent. And it shows unusual and complicated pharmacokinetics, absorption, and the bioavailability are low and variable. There's a latency between administration and effects. This is the amiodarone is highly lipophilic and has large volume of distribution and it's metabolized by the liver. And it has long half-life of 30 to 180 days. So basically, this toxic effect due to metabolize, dicetyl amiodarone is the active form, and there's a high affinity for intra-lysosomal phospholipids, and accumulation of these metabolized as inclusion bodies in the liver, heart, skin, corneal epithelium, and peripheral nerves lead to toxic effects. This toxicity depends on duration of the treatment as well as cumulative dose. So there are numerous side effects and their prevalence in any particular population is variable. Therefore, our main objective is to study about this and describe about this clinical epidemiological profile in our cohort of patients. So this is a descriptive cross-sectional study. Clinical data were collected from patients from who are on long-term membrane therapy more than 1 year, followed at cardiology unit, National Hospital Kandy. And our study cohort comprised 123 patients, where 68 male and 55 female. Age ranges from 19 years to 92 years. Mean age is 61.9 years. Mean duration of treatment is 4.7 years. And the most common adverse effects encountered in this population is thyroid hormone derangement. So these are the common adverse effects we saw in our study: hyperthyroidism, hypothyroidism, increased AST and ALT, hyperpigmentation due to photosensitivity, and keratopathy. So this is the derangement of thyroid functions. So hyperthyroidism seen in 18% of our population, and hypothyroidism about 9% of our population. So we compare the thyroid functional derangement with 3 different populations. One study done in Korea in 2014 and the other one in UK in 1994. So in these 2 studies, in Korean study, the thyroid involvement is much less than our population. And in UK, it is significantly higher than Korean population and bit similar to our data. But in our population, the commonest side effects was thyroid derangement was hyperthyroidism, which is about 18%. So the second most common adverse effect is the hepatotoxicity, elevated transaminases level. More than twice of the upper normal transaminases seen in 21%. And in UK study, this liver enzyme derangement found in 46%, and Korea it is about 10%. Again, there's a difference. So dermatological complications, 46.6% patient had hyperpigmentation, mainly due to photosensitivity and corneal keratopathy seen diagnosed in 10.6% of population. So amidron-induced pulmonary toxicity is the most serious side effects. Incidence is approximately 5% when the dose is more than 500 milligram per day. However, in this cohort, a single patient does not show any clinical evidence of pulmonary involvement. In conclusion, almost all the adverse effects were not life-threatening. So, increased transaminases level, dermatological complications were reversible with dose reduction and withholding treatment, and the hypothyroidism was managed with thyroxine, and hyperthyroidism was managed with antithyroid drugs. Any of the patients didn't show any visual impairment due to amidron usage, and therefore, despite wide range of side effects, amidron is a satisfactory antiarrhythmic agent which can be used for many life-threatening and refractory arrhythmias. These are my future directions. Our study is a single center study, and it is the single, by far, there are no any Sri Lankan studies regarding amidron side effects. So multi-center study may need to generalize these findings and to identify less common adverse effects, which has not noted and in it increases the necessity to conduct further research to find out why our population is having any reason to have any hyperthyroidism with amidron usage. These are my references, and I would like to pay my sincere gratitude to my teachers for their guidance. Thank you very much.
Dr. Disnayaka, now the paper, please hold on because the question would come. The paper is now open for discussion.
Is whether they have reported any of the side effects to the pharmacovigilance monitoring center at the NMRA.
Madam, I can't hear.
No, the question is that whether, because in Sri Lanka, all the suspected adverse drug reactions have to be reported to National Medicine Regulatory Authority, whether you managed to report any of these adverse drug reactions.
Actually, madam, these are known adverse effects. None of them were reported because actually,
okay, Dr. Dissanayaka, but as per Sri Lankan criteria, it is not categorized whether the known one or unknown one. So now that you are more research knowledgeable in this area, hope that you can promote this ADR reporting in your hospital.
Yeah, ma'am.
I had only one question. In your cohort, did you exclude the patients who were on any other medicines?
Actually, madam, yes, patients who are with hypothyroidism or hyperthyroidism, on the when we are starting amidron, excluded from. And
no, in your study cohort. No, yes, I'm asking about your study cohort, whether they were on other medications also.
No, madam, actually it is difficult because these patients is having a lot of medications because all the patients is having cardiac problem. They need a lot of medication, so it is difficult to do that. But we want to see any interaction with, because sometimes patients with multiple drugs like beta blockers, amidrons, and digoxin, those and statins. So whether there is a connection between this interaction between amidron and other drugs, madam, we want to see that part.
Okay, thank you, Dr. Dissanayaka, from joining from Kandy.
Thank you, madam.
Keep joined in to listen to the other presentations. Thank you.
Thank you, madam.
Now we thought we'll give another chance for the oral presentation, presenter 5. So Ms. Nisansala, the paper is determining the quality of extemporaneously compounded individual unit dose powders of furosemide and propranolol used in pediatric patients and improving the method of compounding. So can you now start your presentation? If not, don't worry, your recorded presentation is with us, we can play it. She has started to screen share now, right? Yeah, good slideshow. Can you say testing 1, testing 2, Nisansala?
Testing 1, testing 2. Can you hear
There
me?
must be some problem in her. Because she has now followed our instructions.
Can you hear me better?
Recorded one. Nisansala and other co-authors, please bear with us because it's not being connected. We are going to play the recorded presentation. It is exactly the same.
Good afternoon, ladies and gentlemen. I'm Buddhini Nisansala, and I'm presenting the study titled Determining the Quality of Extemporaneously Compounded Individual Unit Dose Powders of Furosemide and Propranolol used in pediatric patients and improving the method of compounding. First, let me introduce what extemporaneous compounding is. The US FDA defined extemporaneous compounding as the process of combining, mixing, or altering ingredients to create a medication tailored to the needs of an individual patient. Due to lack of commercial availability of pediatric doses of certain medicines, unit dose powder packets are extemporaneously prepared and dispensed by pharmacists. Therefore, in this study, we focus on the quality of unit dose powder packets dispensed as extemporaneous preparations for pediatric patients. The objectives were to determine the quality of unit dose powders of furosemide and propranolol and to improve the method of compounding to meet the quality requirements. To achieve the first objective, first we test the quality of unit dose powders currently dispensed by pharmacies. To obtain powder packets dispensed by selected pharmacies, we use the mystery shopping method. Ethics approval for mystery shopping and sampling was obtained from the Ethics Review Committee, Faculty of Medicine, University of Colombo. And the quality testing of the purchased powders were done according to the British Pharmacopoeia 2015. As these powder packets contain very small amount of the active medicine, to determining the amount of medicine in each powder packet reliably, the assay method used to determine the amount of medicine was first validated. Amount of the drug contained in each powder packet was determined using a calibration curve. We conducted 2 tests given in the BP on the samples we obtained from the pharmacy, and these tests were the uniformity of dosage unit test and uniformity of weight test. Moving to the criteria used for determining the quality of the products. Uniformity of dosage unit test gives evidence of how consistently the amount of the active ingredients is available among the dosage units. For the uniformity of dosage unit test, individual powder packets were assayed. According to the BP, the calculated acceptance value for this test has to be less than or equal to 15. In the uniformity of weight, we weighed 20 dosage units individually and average weight was obtained. According to the BP, only 2 individual weights are allowed beyond a 10% deviation of the average weight. Additionally, no weight of an individual unit should be beyond 20% of deviation of the average weight. Results of the quality testing of the samples obtained from the pharmacy is given here. As you can see, all quality testing results were not acceptable according to the criteria given in the pharmacopoeia. Therefore, we continued our study to fulfill our second objective, which was to improve the current compounding method used by the pharmacists to improve the quality of unit dose powder packets. New compounding methodologies tried and tested. First, we prepared powder packets by replicating the traditional compounding method used in the pharmacies in the laboratory. Active ingredients and the diluent lactose were mixed using the doubling up technique using a mortar and pestle. And powder packets containing 50 milligrams and 200 milligrams of the powder blend were prepared. Uniformity of dosage unit test was conducted on these powder packets. However, the results were not acceptable. Several new compounding techniques were used to prepare powder packets, and the quality was tested at each time. As an improvement, we changed the mixing technique to diffusion with bag mixing and also introduced sieving of the powder blend through a 40-mesh sieve. However, the results obtained from this technique too was not as acceptable. Therefore, we further improved the technique by changing the first steps of the compounding process. First, the ingredients were grounded separately and then passed through a sieve before mixing. These resulting powder packets were also tested for uniformity of dosage unit. This time, the results were acceptable according to the BPS standards. This newly developed method was applied for powder packets produced from powder form of raw material standards as well as from crushed powders obtained from tablets of furosemide and propranolol. Summary of the results we obtained from the all compounding method is given here. As you can see in the table here, the acceptance value obtained from the first three techniques were more than 15, which is not acceptable. However, the acceptance values obtained from powder packets prepared using the improved technique was less than 15, which is acceptable according to the BP standard. Moving on to the conclusions, according to the results we obtained, furosemide and propranolol powder packets obtained from a community pharmacy using mystery shopping did not conform to the BPS standard. And also, we were able to improve the traditional method of compounding in order to improve the quality of the powder packets to meet uniformity of content test. Based on our findings, we recommend to have a SOP for compounding unit dose powders to be used by the pharmacies. And also, our findings strongly suggest having a quality assurance program for extemporaneously compounded medicines in Sri Lanka. Some of the key references used. I would like to acknowledge these persons for their support and the guidance to conduct this study. Thank you very much.
Thank you, but I don't think we can take up questions, no? Because she is not connected or able to answer online. So we may have to forego the questions. So with this oral presentation, we have concluded the abstract presentation sessions, and those who have joined here on site would be given a certificate of presentation and appreciation. Let me call Dr. Vedasinghe, sorry. And Dr. Sujivani Kurugula would be giving out the certificates. Come. Come up and get this. Dr. Amarasinghe and Dr. Gunasegara.
Thank you very much, madam. That brings us to the end of the oral presentation sessions. To hand over a token of our appreciation to the two chairpersons, I would kindly like to invite Professor Rohini Fernandopulle, President of the SLACPT. Call to Dr. Sujivani Kurukurusurya. And then to Professor Shalini Sri Ranganathan. Thank you very much, Madam, and also to the two chairpersons. And I would also like to thank all the presenters who joined here and also joined online. There were a few technical glitches, but I suppose that is the new normal. So please do bear with us. We are slightly behind schedule. So next, ladies and gentlemen, we are moving on to the third and final symposium for the day, which is on teaching pharmacology to medical students in the 21st century. So to start the symposium, I would like to invite Professor Lal Jayakodi, Professor Emeritus, University of Colombo, to be accompanied by Professor Govinda Ponnaperuma, Professor in Medical Education, also from University of Colombo. Over to you, sir.
Good afternoon, ladies and gentlemen. Let's start this third symposium. This is a topic very close to our hearts, the topic being teaching pharmacology in medical and nursing curricula. This session will be co-chaired with me along with Dr. Govinda Ponnaperuma. We have 3 speakers and it is 20 minutes each. The first, we have 1 overseas speaker and 2 local speakers. We have the first speaker is on by Dr. Chen Zing. Sorry, Dr. Chen Ziong. He's based in Singapore. He's an assistant dean in education at the Yong Lu Lin School of Medicine, University of Singapore, National University of Singapore, Singapore. In education field, Dr. Chen is Deputy Education Director in Physiology and a CENMED Associate. He is APB SEA Chairperson and IAMSC Board Member. Dr. Chen is Principal Investigator of Neurodevelopment and Cancer Laboratory under National University of Singapore Medicine Cancer Program and KKH Joint Scientist and an NCIS affiliate member. He is also King Edward VII Hall's Resident Fellow, where he lives among health profession and life science students. At Medical Science and Health Profession Crossroads, Dr. Chen is exploring ways to enhance transdisciplinary education with specific interest in the role of medical science in health profession education, medical education technology, and faculty development. May I request Dr. Chen to make his presentation, please.
Thank you very much, Professor Jayakodi. And it's great to see my good friend, Professor Govinda there. A big hello from me to you from Singapore. I wish I could be there and you will be showing me around in Colombo. But I guess we'll have to wait till the next time. So first of all, I would like to thank Dr. Tilanka Senaviratne and the Sri Lanka Association of Clinical Pharmacology and Therapeutics for the very kind invitation for me to share with all of you today. All right. I'll prepare to share screen at this point, and if you do not see my slides, please let me know. All right. So when I was first asked by Lanka whether I would like to share about how do we teach medical students in the 21st century, right, way back in late 2019, I had in mind about sharing some of the different aspects about medical education at the National University of Singapore, of which, of course, Gominda would be extremely familiar for having played a very instrumental role in shaping medical education in Singapore. Well, it looks like COVID has forced us, all right, to change the way we teach and learn, and has definitely advanced our techniques by at least 1 century. All right, so I think it would probably not be teaching medical students in the 21st, but we might also perhaps be ready to teach students in the 22nd century with COVID, forcing us to mature and adapt along the way. So I thought that I would change today's presentation to a conversation on online teaching and learning, which might be a little bit more for the times, and hopefully some of our experiences will be something that we could have an exchange of ideas between our Sri Lankan friends and our Singaporean friends, so that we can see how together we can do better in terms of online teaching and learning, whether it's pharmacology or other areas of discipline. All right, so as educators, our role primarily is to deliver information, all right, that is basically data that is contextualized, all right, and present information to our students, and then hopefully, all right, use a certain pedagogy that will allow our students to connect this information, all right, into different knowledge nodes, and that actually connect, relate, and talk to one another. So I think that as educators, we want to kind of use pedagogy that allow us to move beyond just the delivery of information and knowledge to something that will actually stimulate our students to develop insights for themselves, and hopefully ultimately to wisdom. Of course, we don't want to overdo it, as you see in the last slide, where there's simply just a lot of conspiracy theories and a lot of fake news that is going around. So the question that I asked myself today before I came for this talk was really, what do my colleagues in Sri Lanka want to know? And I'm fully cognizant that I'm talking to a room full of clinical pharmacology and therapeutics experts. And I know that I'm no expert in this area. In fact, I'm actually from the Department of Physiology and also a pediatric cancer scientist. So I was kind of worried when Lanka asked me to share. I was wondering, whether what I share would be relevant and helpful to our colleagues in pharmacology. However, what I'm about to share in the next 15 minutes or so is really about my experience in teaching physiology to some healthcare students, and some of the approaches and strategies that I use, which hopefully will also be applicable to our pharmacology teachers. So when we were asked to go full online sometime in March, I guess there's two things that are extremely important in our mind as educators. The first thing is to adopt an open-minded mindset. And the second is to tell ourselves that to try new things. So that was the two things that I kept at the back of my mind, even though there were a lot of uncertainties, there were a lot of difficulties to deal with, especially in terms of the technical aspects, not to mention in terms of the pedagogical unknowns. Well, the question was that who were the unlucky students who were going to experience this new way of teaching and learning? So today I'll share with you my experience about teaching physiology, specifically respiratory physiology, to our dentistry students. All right, so a little bit of profile about these students. These are first-year students. They are 19 to 21-year-olds, mainly Singaporeans. And it is important to note that this is also my first encounter with them. And the number of students are about 73. Now, these are students who are going to university in a very unprecedented time, right? They miss the opportunity to have face-to-face orientation with their classmates. And obviously, the social interaction dynamics differ from previous year. And that too can lead to a lot of unknowns when it comes to teaching and learning experiences. But there were, on top of that, as if COVID did not present a big enough challenge, there were other potential challenges even before the class started. Well, first of all, the class, this particular dentistry class basically was larger from the previous years as the nation increased the intake, hoping to produce more dentists to meet the country's needs. The second thing was that online teaching and learning obviously brings with it a very serious sense of screen fatigue. And then this was a clear unknown to the students as well as to myself. And having to go 100% online was obviously something that was a very uncharted territory. So what else, that are considerations that we need to consider when we teach our students in the online sphere? Another thing to note is that I'm not sure about the intake for medical students or health profession students in Sri Lanka, but in Singapore, for example, in medical students and in dentistry students, some of our students do not come with prior biology background. And even for some of them who do, they do have different levels and different understanding of biology background prior to entering medical or health profession school. So that presented another challenge where students are now at the same starting point, but they have different beginnings. And clearly, it is very difficult to use a one-size-fits-all approach that will meet the needs of all our students. So the first thing in my mind was there's a lot of unknown, there's a lot of challenges, and what do we do with unknown and challenges? The first thing we do is to always experiment, right? Never stick with the tried and tested only. And we talk about stay safe and stay well, but I guess in the area of teaching learning, I guess there's room to take some risk and to try new things. So I had 3 sessions with the students, and we did a little bit of a study and using 2 different pedagogy to deliver content to the student. Well, in the first lesson, what I call the intervention lesson, this is like a new management, a new protocol, and in terms of treatment in the learning sense. All right, this is what I call the intervention lesson. So I applied the flipped classroom pedagogy. And then just to make sure that in case this particular pedagogy doesn't quite work out in the 100% online setting, all right, we make sure that the other lessons actually fall back on the traditional online teaching and learning methods that we all understand, which is direct instruction. All right, so in terms of direct instruction, this is a little bit more straightforward. So this is just like the way I'm teaching it. I mean, I'm not teaching, but the way I'm delivering my presentation to all of you right now. It takes place in a very linear progression. Well, there's still interactive elements there with poll everywhere, with scenario and video, but basically it's the lecturer who's talking and then students who come on from time to time to answer certain questions. Now, in terms of the flipped classroom, there's a little bit more preparation work there. There's a pre-lesson component whereby I created bite-sized recordings of about 2 to 8 minutes, and we let the students know that they have to watch this prior to coming. And these recordings are ultimately going to form the core content of what they know, what they need to know for that lesson. And then I communicated the learning rationale, why I was taking that approach and what I was hoping to achieve. And during the lesson itself, there was actually, the time was actually not spent delivering content. It was spent a lot on rapport building because it was the first time I was meeting them. It was a lot of time going through productive higher order questioning and clarification using scenarios, videos, and poll everywhere. And in short, the time was actually shortened to make sure that the total time of our student interaction with the learning event is now split between asynchronous learning at their own time and also the face-to-face that they have with me. So these are some of the videos that I created, and the actual contact time, which was meant to be 1.5 hours, is now cut short to about 1 hour. Well, having said that, even though we are trying different pedagogy, a few things, a few things that are bread and butter, we make sure that we keep the same. For example, on online teaching and learning, we make sure that lesson norms, regardless of the pedagogy or the mode of instruction they're going to use, lesson norms need to be established. And we always explain to our medical or health profession students how the lesson norms actually relate to their professional practice. So it is a way of implicit curriculum to basically share with them some ideas about professionalism and professional behavior. Activating prior knowledge, again, very important, regardless of the pedagogy that they're going to use, because again, so important because the students come from different backgrounds, and it helps us to know where they stand in terms of their prior knowledge and how we can adapt our lesson content and our lesson plan better. Contextualization is again also a bread and butter, regardless of the pedagogy they're going to use. So in dental patients, a lot of dental students don't see the relevance of studying physiology, especially respiratory physiology. So contextualization is important. For example, we share with them how a dental patient with emphysema, how should they be positioned such that it doesn't exacerbate their emphysema, and how asthma patients, for example, can present with certain dental conditions. Another example is, for example, how breathing sounds and breathing signs and symptoms can actually be a clue to a dentist, and in the process of doing a dental extraoral examination, it can actually lead to an incidental endocrine finding, and really showing them how the different aspects of physiology intersect and how it can still be relevant for dentistry as well as other allied health professions. And then finally, always pediatric dentistry never see the importance of ventilation volumes in respiratory physiology until they see it in the context of anesthesia. So those are the standard things that we keep regardless of the pedagogy that you use as far as online teaching and learning is concerned. But in terms of using the flipped classroom pedagogy, I think the time that I spend with the student, one thing that we need to remember is that less is more. All right, so I try to avoid overwhelming the slides with a lot of data, with a lot of words, and really it is basically a case scenario. So for example, here are two pictures which I will share with students, asking them which aspect of the respiratory system is affected. And they will share with me, for example, obviously ventilation is affected, but then how do the mechanisms differ and what are the first principles? So one way is to share with students how day-to-day information can be built into our teaching and learning activities, and how they can help us to think about aspects of healthcare that sits at the intersection of socioeconomic problems as well. All right, so less is more. The third aspect about the flipped classroom pedagogy is really about post-lesson follow-up as well. So ignore some of the first 19 comment that I was wearing a nice shirt. So students like to have a little bit of fun and make fun of their lecturers once in a while. But really having the asynchronous follow-up with them to follow our students' learning, getting their feedback, getting their reflection and questions really helps us and inform us to plan our next lesson much better. So the entire process of using the 3 lessons that I have with them to explore the traditional direct instruction on online teaching and learning versus the flipped classroom approach to teaching online teaching and learning falls under what we call the inquiry teaching. In other words, we are always asking questions about how our students are learning in terms of the methods and the pedagogy that we are applying. So in the first lesson where I used the flipped classroom pedagogy, we achieved 80 to 90% of video because we encourage our students to actually turn on their video. Of course, we understand that this is subjected to bandwidth as well. But as far as possible, we do encourage students to turn them on. And typically in lessons, students do not turn on their video. But here, because it's not just me talking for 1.5 hours, we are actually talking in small groups and then later on in a big group. So we actually get the majority of students actually automatically want to turn on the cameras, and they're motivated to turn their cameras on because they're now actively learning and also participating in the discussion. And then the students also gave very positive feedback. But I think the important question is asking them which one do they like? And which one do they like sometimes may not necessarily correlate to which one is more effective, right? Because we all know that sometimes things may be effective, but they don't like it, right? And things, they may like certain things, but they may not be as effective, all right? But I think our preliminary assessment comes back to show that actually this particular cohort performed much better actually than the previous cohort. So it's still early days. We still have some data to collect, but I think we're quite positive about how this is turning out. Of course, we need to be conscious that when you try new pedagogies in teaching, whether physiology or pharmacology, students say, oh, this is fantastic, this is great, everyone looks very positive, they're happy. There's also a novelty bias as well. The important question is that will they continue to remain engaged and excited and enthusiastic after a semester or even after an academic year? But there are clear advantages of the first approach of using flipped classroom in online teaching and learning. The first thing was that the set of recordings that I made that I put onto our learning management system is really a revision resource for our students that really need to know topics, and so students could go access them anytime they want, and they could revise them, and it takes no more than 30 minutes in total instead of listening to a 1.5 hour lecture. The second thing was it helps me to track students' pre-lesson engagement, and it helps me to understand their motivation. So the system allows us to see how many students view the videos, how many times they view it, when did they view it, and then exactly which point did it start, which point did it stop, and so we know the level of engagement in each of these videos. So it gives us a very, very solid evidence about the level of students' motivation, and as an educator, it helps us therefore to tune up or tune down the things that we do in order to increase their motivation. And finally, we are able to engage with the students with more advanced content and facilitate higher order thinking by using the flipped classroom learning approach, because now the face-to-face time is used for higher order questioning. All right, so I'm coming towards the end of my sharing session, but there are some questions. I know it's unusual, usually presenters get questions, but I also hope that I will leave some open-ended questions for you to think a little bit about and explore on your own. And obviously, I'll be very happy to keep in touch with you via email or any other means, or even through Gominda or Lanka later on. So these are some of the questions. Does flipped classroom really lead to flipped learning? And what are the difference between them? Right? Is self-directed learning truly self-directed? Right? If you don't do anything to the students, will they really go and pick up the videos and watch them? And will they really go through the material? And often I think a lot of educators focus a lot on the mode of instruction. People are very concerned, is this didactic? Is this interactive? I think the question to all of us today is that should we be focusing on the mode of instruction, or should we really be seeing the mode of instruction as the overall pedagogy and how this pedagogy is suited in our own respective cultural context? So some practice points as an educator in this new online teaching and learning era. And we don't know how long it is going to stay, but we're pretty sure that even if we go back face-to-face, the online teaching and learning space is definitely going to be increased, not decreased. So we need to leave a lot of time and space for reflection and interaction. And I think this is not just for the students, but as educators, instead of going for lesson after lesson, we do need time and space for our own reflection in order to be better educators. The second is to monitor and observe and continuously adjust our practice. And the third point is that the teacher here is really not at the center of the education, right? The teacher here is not teacher-centric, but is student-centric. And in a flipped classroom model, the teacher is a facilitator rather than a person who is the guru and delivering all the content and knowledge. The fourth thing is to realize that, now because we don't see our students, it's even harder to know their struggles and to know their background. So all the more we have to think of different ways to differentiate our students and to be able to have a two-way feedback on how they're learning and how they are assessing what we are trying to deliver to them. The fifth is to maintain availability, all right, in real time meaning that we are available. The flipped classroom actually allows me to be available to them, all right, for discussion. Like right now, I don't think, even if you want to say something to me, I'm not really available because, I keep on going like a steam train, talking and talking. So, but in the flipped classroom, that availability becomes more obvious and then also available offline as well. The sixth point is to constantly obtain data about the students' learning so that it can inform our future practice, and to always engage with other educators in platforms like this, for example, to always improve what we're doing in the online classroom. So finally, how can we prepare ourselves in this era of online teaching and learning like today? Number one is to be situationally aware. Now, for example, right, it's a difference if you're going to use the same pedagogy or same mode of instruction, whether you give a student who's fresh up from bed at 8 a.m. or whether you're giving the lecture at 6 p.m. at the end of the day when it is a 10 lecture that the students have encountered. So I know many of you must be pretty tired by now because this is the last session. So it makes sense for me to take 20 minutes and not 200 minutes. So I think being situationally aware is very important. Leverage on our strength. All right, different educators have different personality. All right, if you're good at humor is a fantastic teaching tool. All right, but if you have other strength and humor is not one of them, then I would suggest not using humor but using something else. So always be aware of our own strength, and then but at the same time challenge our weaknesses as well, right? I think as educators, I don't know about the educators in Sri Lanka, but in Singapore, many educators, the biggest weakness, the biggest thing they challenge themselves is actually using new technology and being adept at manipulating and also navigating around new technology. So I would say that, when we challenge those weaknesses, it's okay. For example, when someone doesn't turn on the video, it's okay when someone struggles to turn on the microphone, right? Because we all make mistakes. And I think that when students see educators make mistakes, and we are able to learn from them and humble ourselves to learn from each other, I think the students also get a hidden curriculum about humility from them. And then finally is to know our learners. All right, so the Sri Lankan students obviously have similarities and differences from Singaporean students. And then knowing our learners is a continuous process, right? So this is a picture of my wife, right? So, we may know our learners 10 years ago and we could sweep off our learners off their feet, right? With our teaching pedagogy and our teaching styles. you know, but after getting married for like 15 years or 16 years, right, we still use the same style and we still use the same approach. Clearly, you know, our spouse is not going to be very impressed. This was actually me trying to celebrate a birthday with an egg instead of a cake because I couldn't find any cake. But having said that, you know, adapting is very important. And so we need to continuously know our learners, all right, and continue to find new ways, all right, to engage them so that we can enhance their learning. All right, with that, thank you very much. And I look forward to your questions and comments.
Thank you very much, Dr. Chen, for that brief description of the innovative teaching methods that we are doing in Singapore. We will take some questions after the rest of the presentations. So we will come back to you in maybe after 40 minutes or so. So please bear with us. May I request Dr. Ponam Peruma to introduce the next speaker.
The next speaker is Dr. Tilanka Seneviratne, MBBS, DCH, MD, Pediatrics, MRC, PCH, is a consultant pediatrician and a senior lecturer, Faculty of Medicine, University of Peradeniya, Sri Lanka. Graduated from the Faculty of Medicine, University of Peradeniya, Sri Lanka. She continued postgraduate studies in pediatrics and child health and received Doctor of Medicine in Pediatrics from University of Colombo. Then she went on for further training in pediatrics in the UK and received the membership of the Royal College of Pediatrics and Child Health of the United Kingdom. Currently serving as a consultant pediatrician and senior lecturer attached to the Department of Pharmacology, Faculty of Medicine, University of Peradeniya. Her research interests are in asthma, allergy, clinical pharmacology, and simulation-based medical education. She is also the Vice President of the Sri Lanka Association of Simulation in Healthcare. So without any further ado, may I invite Dr. Seneviratne to make a presentation.
So good afternoon to all of you. I hope you all can hear me.
Yes, yes, we can hear you.
Thank you. And I'm quite thankful to Sri Lanka Association of Clinical Pharmacology and Therapeutics for giving me this opportunity to deliver this lecture. So today I'm going to discuss about integrating pharmacology with clinicals, the role of simulation. The outline of my lecture, I'm going to discuss about why integration is needed and the simulation for integration and the state of the need for simulation in this era of COVID-19. So why we need integration in pharmacology teaching with clinical teaching? The pharmacology, as we all know, is an integral part of clinical medicine. We tend to teach pharmacology mostly in the third year, but the clinical training for medical students goes, most of the clinical training goes in the final and fourth years. So there's a time gap to bridge between learning and using pharmacology. What else? Students do not fully understand the clinical stuff when you teach in the third year. So there's a knowledge gap to bridge between the time you teach and also the time you practice. And when we teach pharmacology, we teach the drugs and they had to apply that to the diseases. Whereas in the clinicals, when you learn them in the next years of their training, they learn the diseases and they have to apply that to get to know about the drugs. So what else? The context-based learning, that is known to be the best way of learning to give knowledge retention. So the most of the pharmacology we teach is based on book teaching. So if we are able to teach pharmacology with the patient, there will be good retention. So there's a paper, this paper says, is about this context-based learning actually. So in the case of medical student, the context-based learning is learning in an environment similar to future practice and profession. If we can teach them the pharmacology in the wards, that will be the best, but can we do that? It is a structured course, relevant clinical materials may not be available when needed, whenever you go to the ward, and it is not an easy task, and it is time consuming. So what is the answer? The simulation, you can bridge the time gap, you can bridge the knowledge gap, you can give some answer to the problem of reverse order, and also there's context-based learning. Now, what are the ways of simulation we can use to teach our students? Role play sessions, high fidelity models. Now, to discuss something about the role play models first, this is something which we did. We divide the students into small groups of 10 to 12, and 2 students acting as doctor and patients. And the patient student simulating the preset scenario, and the doctor has to make decisions. The rest of the group has to comment on the decisions made. So finally, there will be a debriefing session with the teacher, which points out the mistakes done, and that will teach, we teach the subject around the scenario. So what are the topics we can teach with role play sessions? Prescribing antibiotics, how to do therapeutic reasoning, and prescribing in pediatric patients. Now, all of us know that these topics are a bit difficult for the students to really grasp, especially the antibiotic prescribing. So there's always a problem in their mind. May I be able to master this? So unless we do this practically, there will be these problems coming from the students all the time. But this is one of the papers we did actually. We presented this at 15th Asia Pacific Medical Education Conference in Singapore about therapeutic reasoning to teach antibiotic prescribing, which was quite successful. So what are the advantages of role play, using of role play for the simulation? They can learn through the real scenarios. A student get actively involved in the subject. They're not just passive learners. They know what they're learning. And they learn through trial and error, which is the best way to retain the knowledge. Of course, there are limitations of role play, groups of 10 to 15, so it takes time to cover the whole batch. And there's obviously increased workload for teachers. And not all pharmacology can be taught by role play. How can you teach emergency medicine, procedures, adverse reactions? So there, the importance of using models to mimic medical and surgical conditions comes handy. So we use high fidelity simulation where a non-human model mannequin are made closely similar to human patients in appearance and action are used to teach students. This is part of our PAS facility. Now here, actually, I'm quite thankful to Professor Vasanthi Pinto, who I think she's in the audience. She's the person who had a major contribution to bring this facility to our institution. And this is how we did high fidelity simulation with our students. We do that with 4 steps: pre-test, briefing the scenario, implementing the scenario, and debriefing. So we give a pre-test first to assess the students' current level of knowledge, and then we give an introduction to the students about the mannequin, the high fidelity mannequin, and the things the mannequin can do and how the mannequin works. Now, to tell you something about these high fidelity mannequins, they are so closely resemble patients. If you auscultate, you can hear the lung sounds. If you auscultate the heart, you can hear the heart sounds, and you can change those sounds as you wish according to your scenarios, and you can feel the pulse, and you can make them speak, and also the mannequins attached to monitors, so you can always adjust the parameters, so you can run whatever the scenario you want according to the given the information you have fed to the machine. So we give this information to the students first, and we allow, we give them hands-on time so that they can handle the mannequin first. And then we give the scenario with the general outline of the scenario, and we ask the student to run the scenario. So during implementation of a scenario-based teaching, one of the major problem you get is how can we drive the student group to according to the way which we want our scenario to run. So that is the major problem we face. So how can we implement a scenario with an uninterrupted flow in the intended way which we want? Otherwise, the student will not learn the learning point which we want to give them. So in case if the scenario is not progressing as expected, there are ways and means which you can modify or adjust the scenario. The one which we used is to use a confederate, that is somebody acting as a senior doctor or nurse or a parent to prompt and guide students out of pitfalls. And this is one of the instances where such a person comes and carefully change in the students' way of thinking without affecting the realism. So advantage of having a confederate is scenario progression with course correction, not affecting the flow of the activity. That allows going through the learning in a seamless manner. There are other methods of implementing scenario, adjusting the scenario course direction. One method is the pause and perfect, where if you see that the students are not progressing in the way you want, you can stop the scenario and then you can discuss with the students and correct it. But that will not be realistic, and the scenario is no more realistic one, and that interrupt the seamless learning, and that lengthen the scenario as well. And the other method is to run through the scenario. So you do not do anything. You just allow them to do whatever they want. And the scenario might go in an unintended course. That allows optimal immersion of the students to the scenario, and they might end up with a very, very different outcome with the patient. But then you have to rerun the scenario, making the correction, but there's a time factor affecting that, and also that is not going to be realistic in our setting. So, so all of all, the using a confederate was the most practical and most perfect method of addressing this problem. And then comes the debriefing, which is the most important part of simulation. Now you can see here, you can see the smiley faces during debriefing. That is what we want. And during debriefing, that is the time to show the students' reactions and their self-assessment of their performance. And also we use a bit higher order debriefing technique, facilitated reflection. We allow them to facilitate on their, we allow them to reflect on their performance. We just facilitate them to learn what they have done, or what are there any deficiencies of their performance, and if so, what has made them to do that, like that way. And also we do directive feedback as well for certain things, for specific shortcomings, for mistakes and how to correct it. And all these high fidelity scenarios are being recorded, video recorded, and we used to play them back and point out the things which has happened. And sometimes we see students have never realized that they have done it. So only when going to the video playback, only they get to know that this is what went wrong. So that was very, very helpful in debriefing as well as good learning. And we presented this paper on use of performance scale and video playback in the last conference of SLMA. And after all, at the end of debriefing, we teach the subject around the scenario and we give the take-home message, and this is well retained in their heads. So what are the advantages of high-fidelity simulation? We can give real-life scenarios, and there's no difference to real-life patients. So active involvement of the students, the do and learn, the best way to learn. And therapeutic scenarios which otherwise cannot be replicated can allow to be practiced without harm to patients. And you can learn through mistakes. And after all, the satisfaction I treated a patient. We know that students are not going to treat patients fully, but now they have this chance to treat a patient, and that is a great achievement for them. So when to integrate pharmacology with this type of simulation at third year, when learning pharmacology, we can do it, as well as that we can do that in final year when practicing therapeutics. Now, coming back to the COVID-19, that is the major problem we are facing in whole world. Now, we just had a lecture by Dr. Shishong on the new development, what we had to face, the online teaching. Now, this is a very recent paper published at Nature Public Health Emergency Collection, 2020 September, Challenges and Opportunities of Preclinical Medical Education, COVID Crisis and Beyond. And they have mentioned that the lack of hands-on training in the preclinical years may have serious implications on the training in the current cohort of students. So we had to think about the ways and means of giving students hands-on experience in the years to come. We might not be able to send the students to the boards fully to get all the hands-on experience. We don't know how the pandemic will behave. Still, we are not in a state of full understanding about that. So we had to, I think it is in a way unfair by the patient, and it's a way unfair by the students as well to send them to the boards. So in a way, we had to think of alternative ways of giving more opportunities for them to have hands-on experience. So what are the students' view on high fidelity simulation? This is the perception of students which we got in 5-point Likert scale. The questions we asked whether the appropriateness of the course for their present level of knowledge and experience, their active participation, the resemblance to the real life situation, whether they would like to have that as an effective teaching tool to teach clinical drug therapy. So this, you can see this tall blue bars showing the agreement of students for these statements. The majority of the students were quite happy with the program. And this is the same assessment we did for a scenario on acute severe asthma. And antibiotic prescribing and therapeutic reasoning, of course. Again, we asked whether their idea about the rational selection of antibiotic decision-making and prescribing skills. And you can see how majority of students received the course. And there are a few publications we did. This is Sri Lanka Journal of Child Health. We showed the how students actually engulfed in this high fidelity simulation as a positive teaching method. And challenges, of course, we need resources, equipment, need preparation, teachers' work, writing scripts, training staff, practicing, coordinating. It's not merely a lot of work. And among all of these, finding time slots in timetable, simulation is additional time. So we were able to be successful because of extended hours of work and a lot of training. and the teamwork. And I'm just want to tell you, yes, this is the team, including my department of pharmacology as well as staff from Department of Anesthesia and Critical Care. So it is the everybody's help which made everything successful in this my university. Thank you.
Much, Dr. Seneviratne. So please be with us. We will take questions after the next speaker's presentation.
Okay, we have the last speaker, Dr. Roshini Murugapillai. She is based in the Eastern University of Sri Lanka Faculty of Medicine back there in Batticaloa. She joined the Batticaloa University Faculty of Medicine in 2008 and has been there throughout. During this period, she completed her doctorate, and she's been handling the teaching of pharmacology to the medical and the nursing students. And she's also functioned as the head of the medical education unit. So she's a member of our association, and we are pleased to see her. May I request Dr. Roshini Murugapillai to make her presentation?
Good evening to you all. Can you see my presentation?
Yes.
Can you begin the slideshow, please, Dr. Roshini?
Yes, madam, I'm trying, but I think my computer got stuck at this point. Can you hear me now?
Yes.
Good evening to you all, and sorry for that technical glitch. And thank you, sir, for that kind introduction of me. So today I'm here to present the challenges to undergraduate training in pharmacology in a university located in the periphery. So at the outset, when one looks at this title, you wonder whether there should be any challenges different to a university according to the geographical position. So I too faced that challenge when I made up this presentation. So resources in medical education are not evenly distributed, and access to education can be more problematic in rural areas. So that is what I'm going to touch upon today. So the challenges, I'm going to talk in three aspects. One is the geographical situation of the faculty, then challenges faced in the medical curriculum at the faculty in teaching pharmacology, and then there are challenges inherent to the discipline of pharmacology on how to teach it effectively to the students. So the third challenge, I will not be talking in detail because already Dr. Tilanka spent in her initial presentation the challenges in that. And those challenges, of course, are not solely for the peripheral situated university, so it is common for all. But however, during my presentation, we will understand that how the geographical position of the faculty can affect the other two aspects as well. So to start with, I'll give a brief introduction of the faculty. So my faculty is Faculty of Healthcare Sciences, which is located in the city of Patiklo. And it is about 325 kilometers away from the capital city. And the faculty was established after a Gazette notification in 2005. And it was the 7th medical school to be established in the Sri Lanka. And it offers 2 degree programs, both MBBS and BSc Honours Nursing, in which pharmacology taught for both the degree programs. So if you look at the medical schools which were established in Sri Lanka by the year 2006, there were 6 medical schools already established. And as I said initially, Faculty of Healthcare Sciences was the 7th medical school to be established. But interestingly, if we look at the map of Sri Lanka, if we draw a line like that in the middle vertically, we can appreciate that all the other medical schools are situated on to the left of the line. So that leaves this faculty alone in the east side, on to the right side. And this, of course, I will be referring to this map again, because I think this poses a major problem in recruiting staff to this faculty. Maybe because of the distance from the capital city, and maybe it is less attractive. And when the faculty was established in the year 2006, the prevailing civil war at that time also would have prevented people coming to this faculty. And also the highways and the roads, the road network was not well established during that time. And maybe that is another reason by which staff were not willing to come. And this challenge is not only for the discipline of pharmacology, but in general to the faculty. So if you look at the academic staff teaching pharmacology in the faculty, first I would like to talk a little about the organizational structure in this faculty. So there's a radical change, or it is in a normal medical school where you see 13 odd departments and a dedicated department of pharmacology to teach pharmacology. In Faculty of Healthcare Sciences, we have only 4 departments contributing to the medical MBBS program. So we have Department of Human Biology, Pathophysiology, Primary Healthcare, and Clinical Sciences. And it is into this Department of Clinical Sciences where the discipline Pharmacology and Therapeutics also is integrated into. And if you look at the staff dedicated to teaching pharmacology, there are only 2 at present. So there's 1 senior lecturer and 1 lecturer probationary who is currently on study leave. So that's the staff strength that we've been having at this faculty for quite a long time. So why we need more staff, and why we cannot run a degree program with just 1 staff to a program, to a discipline, we all understand. So it is more than to just carry out effective teaching learning activities to the students. It is also to provide diverse experience to the students. Otherwise it will be like boring to the students to learn from a single teacher as well. And also to give feedback on the curriculum, the way we implement. So we need more staff for these purposes. And also, in my next slide, I will be talking about the curriculum, and then we will see how this lack of staff have effect on that aspect as well. Because when you need more voice to be heard so that the pharmacology can be included in the curriculum as effective to effectively deliver the content to the students. So at present, how we overcome this shortage of staff is by using the extended faculty from the teaching hospital Patiklo. So there are positives and negatives of using extended faculty. And all that we have seen is they have been very accommodative to the faculty, not only to teach pharmacology, but also in other disciplines. I would be wrong if I say that there's only accommodativeness that we see from the extended faculty. Of course, we also see some alien looking as an aliens of when pharmacologists go into the ward. So that experience we too have, but I would say that is very minimal compared to the accommodativeness of the extended faculty that we have experienced so far. And virtual classroom, now with this COVID pandemic, now that we have started on with virtual teaching, geographical barriers do not pose a problem to choose a resource person to teach a subject. And this, of course, we used in this faculty to teach other subjects like pathology, forensic medicine. These were we used in 2006, the video conferencing technology to teach the students, since at that time we did not have any staff in the faculty for those subjects. But pharmacology, of course, in this, if we look at the context of this faculty, having at least one staff for a discipline was a luxury. So, and the video conferencing center, the unit was situated in the main campus, which is like 17 kilometers away. So we could not afford to go on teaching different disciplines to those batches at that time. So pharmacology was never taught via video conferencing sessions, but we did have visiting staff coming from other universities. Now to discuss about the challenges in the curriculum, first let me talk about the curriculum at FHCS. The curriculum that we have is an integrated curriculum, and it is organ-based system modules arranged in a spiral model. So there are 3 phases, and semester 1 to 3 is phase 1, semesters 4 to 8 is phase 2, and semesters 9 and 10 are considered phase 3. And if you look at the curriculum map, where pharmacology is taught for medical students is during this phase. So phase 2, semester 4 to semester 8, during this phase 2, pharmacology is being taught. And this phase 2 is divided into 2 major sections because we have 2 summative exams in that. So if you look at the modules are integrated modules. So integration with pathology, microbiology, and pharmacology is what we see in this phase 2. And if you look at the assessments, again, assessments are integrated assessment. We don't have a separate exam for pharmacology. So the questions are made up, integrated with the other disciplines as well. And these assessments are done, as I said initially, in 2 major summative exams, phase 2, part 1 and part 2. So looking at the curriculum and the content of, or the weight of pharmacology that we teach for our medical students, we have in the 4th semester a dedicated module for basic concepts in each discipline. So likewise for pharmacology also, we have a module on general pharmacology, which is of 1 credit. And the other pharmacology topics are integrated in other modules. And integrated modules with pharmacology inputs are about 16. And when I went through the session plans of these modules, 60 different modules, we could sum up saying that about the weight of 5 credits of pharmacology is incorporated into the medical curriculum. And the pedagogy that we use are mainly lectures, problem-based learning, case-based discussions to a certain extent, and large or small group discussions. And if you look at the challenges in the integrated curriculum, the visibility of clinical pharmacology and therapeutics in the curriculum becomes a problem when you have an integrated curriculum. Because everybody wants, if the module is of 2 to 3, the maximum that we have is 2 credits module. So if a module is 2 credits, and then the pathologist wants some time, microbiologist wants some time, and then the pharmacology also wants some time. So the visibility of clinical pharmacology and therapeutics in an integrated curriculum becomes a big challenge. And opportunities to prescribing, to practice prescribing is also minimal during the allocated hours. However, this is overcome by using extra hours, taken from the notional hours, having extra tutorials that can be taken care of. And a robust assessment of prescribing competencies. This is again a challenge in an integrated curriculum because, as I said initially, in our summative exams, we have integrated questions. So if it is like you give a case vignette and then ask questions from all aspects. So there will be questions on the pathophysiology, and then it will be slowly moving on to choosing the drug and then talking about the therapeutics. So when questions are integrated, it is not always possible to integrate all pharmacology related things into one question. And prescription writing, we usually tend to put into the OSCEs that we have in these exams. But however, if there's a 20 OSCE, there will be about at least 1 or 2 prescription writings and not more than that. So these things need to go into formative assessments. But when you don't have it in the summative exams, there's a tendency for the students to just skip that section and then do the other section and pass off that particular exam. So if you look at the challenges in implementing the integrated curriculum, I will be talking about in terms of teaching and learning activities. So even though we say that it is an integrated curriculum, when we implement it, when sessions are conducted, it can be more of asynchronous or a sequential sessions and may not be truly integrated a lecture or something where you have a multidisciplinary input, you have more resource person, more than one resource person at a time to talk about a particular clinical condition and discuss the various aspects. No, it does not happen like that every time. So most of the time it is synchronous or sequential session. So when the students learn the pathophysiology of bronchial asthma, and then sequentially there will be a session planned for the therapeutics likewise. So how we overcome this problem? So we use these case-based discussions. Now we don't have this for all the modules. Certain modules we have included these. So case-based discussions with multidisciplinary inputs we try to do so that we can give the exact flavor of this integrated teaching. Assessments. So as I said initially, the tendency for selective learning by the students, avoiding the pharmacology topics, and you can still pass the exam. So this was the case in the past, and then what we do now is we have a carefully planned assessment blueprint where we make sure that certain amount of pharmacology is also questioned so that students cannot leave or avoid learning certain topics. Challenges in teaching pharmacology. So key competencies in pharmacology, the major 3 competencies, the planning appropriate therapy for common indications, writing a safe and legal prescription, and providing patients with appropriate information about their medicines in a meaningful way. So these are there in our learning objectives as well as in any other medical curriculum. The challenge is how should this relevant information be delivered and assessed? So as stated by Simon Maxwell in 2012, teaching medical students to rationally select a prescribed medicines in a scientifically sound and safe and effective manner is regarded as a challenge in medical schools. So this is not something specific for a university or a faculty which is in the periphery, but it is a common phenomenon to all the medical schools. And the same challenge is true for us as well. So if you look at the teaching of pharmacology, the traditional learning had been like, you are told what we need to know, and then students memorize it, and then problems are assigned to illustrate how this can be, the learned knowledge can be used. So this had been the traditional learning, and then this memorizing part becomes a problem. And even today, when you talk to a medical student and ask what's their favorite subject, pharmacology never comes up. And the students' attitude towards this discipline, if you look at, it comes from the previous generations, from the seniors' input and from the previous generation, that pharmacology is a tougher subject where you need to memorize the names of the drugs. So students have that prejudice. So I would say it's a prejudice. Like they come with this thought about pharmacology into this course, and then that doesn't allow them to actively participate in the learning of pharmacology. So in order to break this off, what we have now is to do it the other way, present the problem first and then identify on their own what you need to know about it, and then learn and apply to solve the problem. So now we are moving more towards from the teacher-centered teaching learning activity to more of a student-centered teaching learning activity. But to do this, the major challenge that we face is the attitude. And it is not only the attitude of the student, but it is also the attitude of the staff to adapt these new methods of pedagogies so that more of student-centered learning can be provided. So when I say attitude, as I said initially, it is the attitude towards the discipline, like I said before, and then also to embrace these learning strategies other than lectures alone. So in my experience, when I do any student-centered teaching, say for an example, if there's a tutorial to write a prescription or to give a case scenario and then discuss about the therapeutics, students like the pedagogy, but then in the student feedback, they give good rating, but also in the suggestions, they say that they prefer the lectures more than this. So student feedback, as Professor said, even though they like it, the liking may not be equal to say whether it is effective. So changing the students' attitude into an active learning mode is a bigger challenge that we have. So to sum up, the challenges for a university located in the periphery in teaching pharmacology, I would say the short of human resource is the primary thing, which has influence in the other aspects as well. Visibility of pharmacology in an integrated curriculum, problems in implementing the curriculum, and attitude towards teaching and learning pharmacology. So with that, I stop. Thank you very much. And I thank SLACPT for giving me this opportunity to share my thoughts. Thank you.
Okay, thank you, Roshni, for that brief and interesting presentation. Now, although we are running about 15 to 20 minutes late, maybe we can entertain one or two questions. Okay, if there aren't any questions, we will close this session. So thank you very much.
On behalf of the association, I would like to thank all the presenters who joined remotely for this session, and we would like to show our appreciation in the traditional manner. Thank you very much. And also on behalf of the association, I would like to invite Professor Shalini Sri Ranganathan to give away the mementos to the two chairpersons. First of all, to Professor Lal Jayakodi. And also to Professor Gominda Ponnamperuma. Thank you very much, madam, and thank you, sir, for spending time with us and chairing the session. Ladies and gentlemen, we are now moving on in the agenda, although we are running a little behind schedule. We have a very interesting plenary lined up. The speaker is very famous and I would say an international celebrity when it comes to clinical pharmacology. So without much ado, I would like to now invite Professor Rohini Fernandopulle, who is the president of the SLACPT and also a senior professor of pharmacology at the Sir John Kotalawala Defence University to chair plenary 3. Over to you, madam.
The third plenary is the speaker is Professor Krisanta Veerasurya, who needs no introduction because I think all the current and the past and the current medical students all know him because he keeps, though he has left our university quite some time ago and joined the World Health Organization, he comes in and out. So I think most medical students and now doctors know him. And his interest in Senaka Bibile and on joining the World Health Organization, he was the regional advisor in essential medicine in Southeast region, New Delhi, and then subsequently he moved on to headquarters in Geneva, where he was the secretary of the expert committee on essential medicines. On retirement in 2014, he continued assignments for the WHO and was the CEO of the National Medicines Regulatory Authority in Sri Lanka for a short time when the new drug act was being implemented. Since then, he has worked in drugs for neglected diseases and healthcare systems in low and middle income countries. He has fond belief, eternal hope, and an optimistic outlook that medicines will be primarily for health in the country that still nurtures and educates him. He also hopes the current generation of clinical pharmacology will continue the value ethics, professionalism, and attitudes that we taught them, which in turn were taught to him by the pioneer of clinical pharmacology in Sri Lanka. The floor is over to you, Krisanta.
Thank you very much. Can you hear me?
Yes.
Okay, I have shared my screen. Can you get it up, please?
Yes, we are viewing.
Okay. Is the screen being shown? Shall I restart the share? Okay. Do you see my screen now?
Yes, we can see it.
Yes.
Okay, right. I will then start the presentation. I have been listening from the morning to the presentations that have been made. And to me, the scope and breadth of what was said is a fitting outcome to what the pioneers in Sri Lanka in clinical pharmacology, Professor Bibile is mentioned here, but there was, of course, Professor Lionel, and then after that, along with that, Professor Kotekuda and many others that followed. They would have, I think, been amazed at what we, the present clinical pharmacologists in Sri Lanka, have achieved. They started off as one small department, but what we have become now is almost unrecognizable. So to move on, the declaration of interest, as usual, I have, as you can see it up on the screen. I was actually thinking whether the SLACPT should probably have a blanket statement that all the speakers have made declarations of interest and that there were no conflicts. This is important because as clinical pharmacologists, we are often at the interface of these issues. So if the SLACPT at the beginning of the sessions does make a statement that there had been no conflicts of interest declared by all the presenters, that would be setting a good example for all the other associations. Now, to move on to Professor Bibile, whom I have shown here, he represents the first generation of clinical pharmacologists that was there. And as I mentioned, there was Professor Lionel, Professor Kotekuda, and then Professor Jayasena in the Peradeniya faculty. But he is the one who was the one who blazed the trail for clinical pharmacology. Firstly, he was the first professor of pharmacology in Colombo in 1959. And then it was Ceylon, it was not Sri Lanka, and also the editor of the Ceylon Hospital Formulary. He was also the founder dean of the Faculty of Medicine. And his other interest was medical education. And it gave me great pleasure to see that in the sessions of the SLACPT, there was a session on medical education. So what Professor Bibile envisioned at the very beginning is being continued as we go on. From these 2 points, you may think that Professor Bibile was an academic, but he was more than that. He was the first chairman of the State Pharmaceuticals Corporation. He was an advisor to the United Nations system on pharmaceuticals. This meant that it was just not academic only, but the implementation of something was important to him. The State Pharmaceuticals Corporation began in 1971-72, continues until today, and runs as a very strong thread in the medicines use in Sri Lanka and what it has contributed. He not only contributed to Sri Lanka, but he was an advisor to the United Nations system on pharmaceuticals and tragically passed away when he was doing that. But that shows what his influence was. And it was also important that in 1976, when the non-aligned conference was held in Sri Lanka, where then more than 100 countries participated, one of the agenda items was on pharmaceuticals sponsored by Sri Lanka based on what Professor Bibile had done. So that shows the importance that we had in this particular situation, which brought about something in pharmaceuticals, which has now become worldwide, which began in 1976. But also personally, he was a socialist. He contested actually in the general election because he believed in his principles. And he saw all doctors, and above all, saw doctors and patients as partners in health. There was no command or control. There was no power relationship, but he treated patients as equal. And he was the first clinical pharmacologist in Ceylon, Sri Lanka. And I will digress a little bit here to ask certain questions. We are the Sri Lanka Association of Clinical Pharmacology and Therapeutics. But when we look at all the medical schools that we have, they are all the departments of pharmacology. So there is a contradiction there. What is clinical pharmacology? Clinical pharmacology is this, as all of you know, is the study of drugs in the human species. It's a subset of the pharmacology. And all we do in Sri Lanka is clinical pharmacology. We do not have general pharmacology. However, all our departments in the medical school are departments of pharmacology. Perhaps one day we may change ourselves into clinical pharmacology. We did try in Colombo in the 1990s, but there was opposition. Now there is departments of clinical medicine. Maybe we will one day become, throughout the system, departments of clinical pharmacology. And when did the definition of a clinical pharmacologist come up? I have looked at this and there is no clear statement, but it looks like that there was a WHO document in 1970 which defined what a clinical pharmacologist is. In that we still have a connection. And the connection is in that group was Professor Lawrence. And most of us remember reading Clinical Pharmacology by Professor Lawrence. So there is a continuity, there is a thread of what we are. And so as the Sri Lanka Association of Clinical Pharmacology and Therapeutics, we hopefully will one day not only do the work, but also have departments of clinical pharmacology. Now to move on to the second part of the title that I told you. Essential drugs, the medicines, the concept, and the list. What is the importance and the relevance of this? And why do we still think of this as important? When did it begin? Well, it began in 1975 when the World Health Organization mentioned the concept in 75, and the first essential drug list was in 1977. It has been called the most important global public health tool in medicines. Yes, we have penicillin. Yes, we have streptomycin. We had for TB, and it played a significant role. We have other medicines. But this is the overall tool that has helped the health of the people of this world. And that's why it is considered the most important global public health tool in medicines. Has it persisted? Yes, it has persisted. If you look at the WHO model essential medicines list, it has the 21st is in 2019. There is a small point here. Some of you may know, but I'll just introduce it to you. It began life as the essential drugs list, but it was turned into the essential medicines list later. Why was this? What was the difference? Well, it was actually a change in language. Drugs in the 1970s was always medicinal drugs. But unfortunately, the language changed and drugs became associated with narcotics and dangerous drugs, and it was thought appropriate that it be changed to essential medicines, and that's why the essential drugs list became the essential medicines list. The longevity of the essential medicines list, now you can see, is 45 years, reflects its continuing importance and relevance. There is very little that we can see which has persisted in the same manner in health through 45 years. And that is what is the most important of that. And now I take you back to 60 years ago, from the list in 2019 to 1959 in Sri Lanka. That is 60 years earlier. In my presentation, I switch back and forth between eras. And then in addition, at the end, we will talk about the present list. What did we have in 1959? Our Ceylon Hospital's formula. And all I could tell you is I have managed to get 1 or 2 copies to the Department of Pharmacology, which I found in hospitals. And if any of you do find a copy, please treat it as gold and get it to your department at whatever, even if you have to steal it from somewhere, because this is what built us up. So what was the Ceylon Hospital formulary? It was produced in 1959. This is the scientific basis of the Ceylon Hospital formulary. Who requested that it be produced? It was the civil medical stores which brought down all the medicines for the government health sector. In 1959, as you might, some of you would know, some of you wouldn't, it was the government sector that was predominant and the private sector was small. So whatever that was done in the government sector was the major force in health in Sri Lanka. And what was it? It was to provide information and guidance to prescribers in state hospitals. And the civil medical stores is the one that asked the Department of Pharmacology in Colombo, and they produced it. And how did it come? It came in a Ceylon Hospital formulary as the generic name and international tender. But also was important was the implementation. You could have a formulary, but if you didn't have the drugs, the formulary was not very helpful. You could have a formulary, but if you had many other drugs, then also that was confusing. The civil medical stores imported only the medicines in the Ceylon Hospital formulary, thereby bringing about both the information, a synchrony in the information, as well as the products that were available to the prescribers. The doctors, pharmacists, nurses were familiar with these drugs. If you practiced in Gaul and you were transferred to Kandy or to Batticaloa, then it was the same drugs that were there. There was no question, there was no need to learn new drugs, and that was a very important part of the standardization. And then You would think, okay, that's a very good scientific medical reason for doing this. But as usual, there are other reasons why this came about. The other reasons were that in the 1950s, we had increasing costs, decreased foreign exchange, and which meant that they were unable to get all the medicines that were wanted. There were requests for all sorts of medicines. At that time, there were about 10 types of tetracyclines, plus many brands of each of the time. And the doctors all wanted some of them. And this meant that the civil medical stores could not simply get up the drugs. So the rationalization was requested by civil medical stores, and therefore that was the other reason that we had a Ceylon hospital formulary. How did the formulary committee come about? How did they make the Ceylon hospital's formulary? Here, was it the lone work of a department of pharmacology? No. It was actually the work of the formulary committee, which was centered in pharmacology, but had all sorts of other people, clinicians, pharmacists, who were involved in making this list. And so it was a collective effort that did this. And if you go through some of their decisions, they were actually far ahead of most of the world, actually. I give you this example here. Those of you in the older generation may just remember mention of phenacetin. Phenacetin was metabolized in the body to paracetamol. But phenacetin also produced carcinomas and also nephropathy. These were shown to be later. In the 1950s, it was only suspected that this may happen. The formulary committee looked at the evidence and said, thank you very much. We are going to import paracetamol only. And so therefore, the government of Sri Lanka imported paracetamol only, and the patients in Sri Lanka who went to government hospitals got paracetamol only. That's nice, good. But compare it with what happened. It was only in the late 1970s that some of the countries, including the United States, stopped phenacetin. So in the 1960s, Sri Lanka stopped phenacetin, and it took another 20 years for other countries to stop phenacetin. There was also something that came up in the presentation which made me wonder. You remember the one in pharmacovigilance where there was a picture of thalidomide and the seal limbs, phycomelia, that came about. Sri Lanka, as far as I know, had no such problems. Is it because we were not a sufficient market to send the drug? Or is it because the formulary committee did not allow it to come in? I raised this question, I have no answer. But also, there was another follow-up to this. The Ceylon Hospital formulary wasn't a single publication and that stopped there. No, it was followed up by constant medicines information. And you have the formulary notes, later the prescriber, and provided information on drugs that were in this. So as you can see here, Ceylon at that time, in 1959, implemented the principles, a similar concept and a list, in 1959, 18 years before the essential drugs list. The prime mover in this was the Department of Pharmacology in Colombo, and it was Professor Bibile, Professor Lionel, and Professor Koteguda who were there. And this was what they brought about. By the time the world came to think about it 18 years later, we actually did have a long history of following this principle. Now to go on to the publications that I mentioned. And you can see here the formulary notes, which was volume 1, number 1 in January 1966. So it was not a question of putting out the Ceylon Hospital formulary, but also informing the prescribers of what was being done. And I think you might be able to see in the formulary notes that what we had, there is a article on principles, I will read this out to you, guiding the approval of some proprietary preparations. And it's been written by Professor Lionel. What's the importance of this? It shows that we had a system to approve medicines. Not that we approved any medicine that came, there were some principles, and therefore there were very little combination products, a practice that continues even now, and this was started in 1966. The last item on this was the decisions of the formulary committee during 1965. Again, informing the prescribers of what had been done and what was the reason. And these are things that we in Sri Lanka should be proud of that were done so much earlier. You then have the prescriber that came out, and there you have other drugs that were there. Just to mention, again, a statement written by Professor Lionel and clinicians, and a new drug at that time, ketotifen. So to go back to the essential drugs concept. Essential drugs are those that satisfy the healthcare needs of not the majority of the population. It does not say that essential drugs are drugs that are needed by all the population. A common question to ask is, what do you mean by the majority? Are you talking about 85%, 95%? And the answer to that is, I'm sorry, we cannot give numbers for a biomedical concept like this. We think it's around 90%, but numbers are not possible. And essential drugs should be available at all times in adequate amounts and in appropriate dosage forms. And as I mentioned, it's a focus on important medicines, but it does not discount other medicines. If there is a necessity for other medicines, they will be purchased, but they are not under the condition, under the category of essential medicines, because they are not required for the majority of the population. If there is an uncommon drug, the famous example I give is hairy cell leukemia. That's the only thing I know about that condition. But if you want a drug for that and the patient is diagnosed, then in that case, that drug will be bought. But certainly, it will not be in the essential drug list. Why did the essential drug list come about? And actually, in those days, the low and middle income countries were called the developing countries. And they asked the World Health Organization in the 1970s, how many drugs are really needed and what are they? A lot of the people were saying, we are buying all these drugs, but we have no idea whether these drugs actually correlate with our requirements. We are paying a lot. Are we paying all this? Is it worth it? All these issues were put to the World Health Organization. Drug costs were increasing. More money was buying less drugs. And therefore, the World Health Organization was asked by developing countries to please give us guidance, give us a solution. Sadly, Professor Bibile had passed away in 1976, but Professor Lionel was on the WHO EDL committee, rapporteur, in 1977. And you can see there, this is what we continued. And in that particular situation, you had the first WHO EDL, which is about 220 drugs, few combinations, all of them by generic name, one from the group, for example, beta-2 agonists, and it acknowledged the experience of countries that had such lists, including Ceylon Hospital formulary. One must remember, when I was discussing with some of the people there, they said the experience of Ceylon, Sri Lanka, gave us the confidence to go ahead with this, because we were unsure whether this could be done. Looked nice in theory, but actually, could you have a limited list and satisfy all the prescribers? Could you do this? And we already have enormous problems. Medicines. Is putting this list going to cause even more problems? Well, they said the example of Sri Lanka, and there were two other countries, Mozambique and Chile, made us think that it would be feasible. Then, what did we get? The WHO Expert Committee on Selection of Essential Drugs met in Geneva, and it included a model list and an outline for a program. And it published this book, The Selection of Essential Drugs. Very small, 36 pages, but it had a list. And this list was extremely important because now healthcare systems in the developing world could say, we have a list and this is what we are going to order from. So when clinicians asked other medicines, they were asked to look at this list and see whether there were differences and why do they want their drug when this was on the list. And so therefore, this was a very important tool where the prestige of the WHO, the technical expertise of the WHO was behind this limited list of drugs. Very quickly, this is the inside covers of this, and you can see that this is what we have there, the selection of essential drugs, which was put out in 1977. And I didn't think this would be seen properly. I do not know, but those who are watching it remotely may be able to see that the fifth person on this list was Dr. N.D.W. Lionel, Associate Professor of Pharmacology, Department of Pharmacology, University of Sri Lanka, Colombo. And that was our contribution. What is the influence of the essential drug list, the essential medicines list in Sri Lanka and the world? At the moment, 120 low and middle income countries have essential medicines list. Looks nice, but as I have said, may not have 100% implementation. And therefore, when one is talking about this, you can say they have adopted it, but implementation needs to be improved enormously. Sri Lanka had the first list in 1985, and I'm glad to hear from Professor Asitha De Silva and Professor Rohini Fernandopulle that there is going to be a revision of the list, and the latest was in 2009, so it is time to revise. And also that the focus of the NMRA would be basically looking at essential medicines. If I may go slightly to a side, there was a presentation which showed the analysis of the medical supplies division. And there were some data which were actually remarkable in that sense. If you look at the situations in a lot of the other low and middle income countries, what has been the major medicines by value, by share? They are very expensive medicines, as was there in some of the Sri Lankan ones also. But what was significant? was there were essential medicines in the top 10. Paracetamol, amoxicillin, ferrous fumarate, and so on. So that means we are still using enormous amounts of essential medicines, and they are in the top 10. If we go on to high-income countries, a lot of you have trained in high-income countries, and we'll talk about this. Probably thinking back, do you remember an essential medicines list in the countries that you trained? And I think most of you will probably say, no, I do not think I remember anything about essential medicines when I worked in the NHS UK, or if I worked in Australia, or maybe even in Singapore. Well, that is true. They don't have essential medicines list. That's a name. But in implementation, yes, they do have. I often have this conversation with them saying, so you don't have an essential medicines list? No, we don't have. We can afford all the medicines that we want so that we don't need essential medicines list. Oh, that means all the 12 benzodiazepines that are registered in your country is available for the prescribers. No. We only allow 3 of them to come in there because we have decided these are the 3. And what about your beta blockers? Well, we have 4 of them. So what is this list called? And the list is called the reimbursement list, maybe a limited list, maybe a formulary list. But the principle remains an essential medicines list. Therefore, when you have conversations, if you want to amuse yourself, this is a nice conversation to have. So far, I've talked about the essential medicines and the list. But what is important to remember, it is not only the list, but the focus on the system. The focus on the system which says we look for efficacy, safety, and cost effectiveness. A lot of you now know about evidence-based medicine. If you actually think back a little bit, the essential medicines list was based on scientific evidence. And think back to 1959. Again, it was based on whatever scientific evidence that was there. We took out phenicity. And there were 8 sulfur preparations. And out of the 8 sulfur preparations in 1959, they were brought down to 3. So therefore, it's a question of the system using these principles to come about. Evidence-based medicine, in another name, was essential medicines list in the 1950s, 60s, 70s, and so on. And this system is now being adopted by other systems. Look at medical devices. The same questions are being asked again and again. Now, very quickly to go through the formulary, those of you who have a copy, have a look at what is in there. And you can now recognize that in 1959, the drugs, the medicines that were there are still continuing. Adrenaline was mentioned in a presentation where they said this is what we use in anaphylaxis, and so on. Ergometrin in 1959 was a lifesaver for this thing, for postpartum hemorrhage, and that was what the hospital formulary made sure was available. There was also a critical comment in the Ceylon Hospital formulary. It said, if you do have a copy, read it. There was much doubt as to whether expectorants work. This was in 1959. Those of you who remember the Drugs and Therapeutics Bulletin in 1994, there is a statement which says expectorants are of little value. So you can see that the Ceylon Hospital formulary, some have said that this is probably the first this type of formulary in the world. I do not have evidence to back it up whether it is the first, but certainly it is probably one of the first. So therefore, this is something that was done. Sadly, there were no subsequent editions of it, and maybe it was because of other factors that Professor Bible was and Professor Lionel were involved in other situations, but it would have been nice to have a continuation. What were the principles? Generic name, explanatory notes, classification of drugs, indexing of generic and brand names, adverse effects, doses, and so on. That was there in 1959 and in the essential drugs list in 1977. And now those of you who are familiar with the British National Formulary, well, it began its life in 1981 to 1980. So therefore, the CHF, the Ceylon Hospital Formulary, actually is one of the major, the British National Formulary 20 years later was actually not based on the Ceylon Hospital Formulary, of course, but had the same principles. Well, now I will ask you the question, what has been the major contribution to health of Sri Lanka by the Ceylon Hospital Formulary, medicines and essential medicines? Having mentioned to you all this, most of you would have been thinking, yes, the contribution was to decreasing maternal mortality. We had ergometry. We had good medicines for TB. Did we use that? And then we had drugs that were effective and therefore treatment was effective. Was that also important? Was it the medicines that were important? And the answer is no, it was not the medicines that were important in that. The most important part of the essential medicines, the Ceylon Hospital Formulary, was sustaining the universal healthcare system in Sri Lanka. I do not know, I have looked at this. When did we start this? Late 1940s, late 1950s. We started the universal healthcare system. They talk about the National Health Service in the UK. Well, I think we started it actually before the National Health Service. And why was it important in sustaining the healthcare system? The universal healthcare system is present in low and middle income countries, but with major deficiencies. Sri Lanka is no exception, but we have it much better than that. Why is it difficult to have a universal healthcare system in the countries? First of all, it's the cost of medicines. They are expensive. Second point is a country has to pay foreign currency to buy that, and therefore is a major strain on the budget. Many countries have tried and failed. Recently, an African country said, no, we cannot do this. We are now going to give universal health care to the children. The adults have to pay. Sri Lanka has sustained this. And one of the major supports was basically we were talking of a cost-effective procurement of medicines. The specific list of medicines, cost-effective purchasers made supply sustainable in Sri Lanka. And for those of you who have, through generations, enjoyed the system, at least benefited from universal health care, please remember that it was essential medicines that contributed significantly to sustaining the system. So effective medicines at affordable prices have been one of the major supports to universal health care in Sri Lanka. We now have the question of local manufacture. Yes, it is important and it is a part of the continuing journey, which I will come to later. Local manufacture is important, but it must serve healthcare. Local manufacture is to serve health first and then to get a return on investment. If local manufacture makes profits by making drugs that are not appropriate to our healthcare system, that is not what we want. Now, very quickly, I have talked about the system. But when we ask, so really, what did we gain in this? And here are some of the specific results that we have got. We have eradicated malaria. We had amodiaquine first and then chloroquine and artemisinin derivatives. Yes, you would rightly say we are an island and it was the eradication, this thing that caused this. Yes, certainly, I agree with you on that. But the medicines contributed. Elimination of filariasis. Control of helminthiasis. Last year, there was a publication in Lancet Global Health which showed that it was not cost-effective to do mass worm eradication campaigns because our country did not have that. There were focal points. And so it was recommended that there was treatment only in these focal areas, which was mainly in the estate sector. So we concentrated on mebendazole, available, used, results. Control of tuberculosis. It's a major problem in other countries. Certainly we have not eradicated, but at least we have the medicines to keep it under control. So what was this? We achieved through focus on a limited number of effective, affordable medicines being continuously supplied for these conditions. That was the principle that allowed us to go ahead and cause the success in these situations. And there is one more that I forgot to mention. Control of diarrheal diseases. Death in children is almost unknown from diarrhea. How did we achieve it? Oral rehydration salts made by the government of Sri Lanka and supplied for health without profit. And what was the contribution of that? We didn't require, and when the World Health Organization and other organizations said, would you like the rotavirus vaccine? The answer was, why? We don't have mortality. Why should we be having the rotavirus vaccine? So you can see how using these situations, we have been available, it has been possible for us to achieve our health objectives. So let me try and quickly finish this because I'm running a bit over time. What remains of the pioneering work of Professor Bible in clinical pharmacology? Professor Bible, Professor Lionel, Professor Koteguda. We have a scientific basis in medicines and clinical pharmacology. And the fact that we still continue this, and it is unquestioned that we go ahead and do this, still remains from 60 years ago. We have led to a good medicines registration system. The formulary notes I showed you was the beginning in 1965. And yes, we have a registration system. It may not be perfect, but it is much better than what is available in neighboring countries. We have drug information. Finally, we had Sri Lanka Hospitals formulary, which needs to be updated. But again, we had intermittent attempts to do this. We have the State Pharmaceuticals Corporation. The State Pharmaceuticals Corporation is the overwhelming influence in medicines in Sri Lanka and is the major reason that we have been able to continue these policies. And despite enormous changes in governments, it remains a sustainable, providing a return on investment to the government and providing its role in health. We have a good rationality in drugs that are registered and a very keen awareness of pharmaceutical issues in the medical profession and general public. I mentioned that medicines are generally affordable, but in the presentation on the NMP, you could see that prices were going up. Again, That analysis was due to what was started at the beginning. But on the whole, there is evidence that if we look at the region, ours has the most affordable medicines in the private sector. The issue is that the government has focused on the public sector and has achieved it. Our procurement prices are very, very affordable. The government has not focused on the private sector, and this is the question that needs to be done. Hopefully, with the new national medicines policy, the government can focus on the private sector and then bring about a decrease in medicines prices. After having said this, what I want to ask you is, yes, this is very rosy. Is the country flowing in milk and honey with regards to medicines? And that would be this thing to deny that problems exist. And here is a regulation, here is a list of problems that we have mentioned previously: irrational use, polypharmacy, poor regulation, governance in medicines use in public and private sector. If doctors do not use drugs properly, who is there to ask them, why are you using this amount of medicine? Unfortunately not. It is at the moment just supply only without monitoring. Quality of medicines. We have unregulated sales in pharmacies. Many of the things that are pointed out are said, isn't this a major problem? And the answer is yes. But compared to the other issues that we have, this is something that we need to look at carefully, because it is not possible to regulate pharmacies to that extent that requires enormous resources. And then in that case, in a finite amount of resources, we take away from other areas. So what are our priorities? High prices of some medicines. Unethical, irregular medicines promotion. I will give you one example. When you look at the drug dinners that are put out by the pharmaceutical companies, have you looked at to see whether the non-medical spouses are also invited? If they are invited, that is an abuse of promotion. Why should non-medical spouses of prescribers be invited for these meetings? What benefit do they have? And that is paid for by the pharmaceutical companies, they will say. But in the end, who pays? It is the patient who pays through the prices of medicines. And as mentioned, irregular brand name in brand prescriptions, mentioned in this thing, presentation, where they did not want to change the brand name despite reasons that were not given. So irregular prescriptions by brand name. These problems are common to low and middle income countries, but Sri Lanka has less. You may say I'm optimistic, but at least when you do a look around, and if you look at the situation in India, in Pakistan, in Bangladesh, and so on, one can see that we are very much better. For example, two quick examples. In India, oral rehydration salts are available only in pharmacies. We have pushed it down to the grocery store. Mothers can get it in the grocery store. Pakistan, when we looked at the medicines prices, their prices for atorvastatin was much more expensive than the National Health Service of United Kingdom. So you can see that in that sense, we actually have problems, but hopefully they are lesser. Why is it? Is it of a universal health care and the government system? And now to go on to what will become of the pioneering work of Professor Bibile in pharmacology in the future. It depends on young students who will become doctors trained by clinical pharmacologists and the clinicians who are their teachers. Lead by example, generic name, transparency, no conflict of interest, those of you who teach our younger generation. There will always be a battle between the commerce, market forces versus health of the patients. That is going to continue. But when you can show that the health of the patient matters and that you are on the side of health, you will probably at least help in this battle to talk about health. We need regulation, but it is, as I said, a long and winding road. We cannot regulate much ahead of the general situation. I mean, if you look at public transport, you have problems in the buses. Can we have Rolls-Royce regulation in medicine and Morris Minor regulation in this thing, in public transport? Very unlikely. Regulation is a general situation that has to come about. But probably what is important is personal responsibility for you as teachers to inculcate that you are going to be a professional, and it is your responsibility to students that will be, to patients, that will be the main thing. How can teachers encourage health should predominate? These are the issues that we need to talk about. And so how can teachers quickly, I will go ahead, advocate the essential medicines concept? You need to talk about it. It was mentioned in the Sri Lanka Association of Clinical Pharmacology. There were presentations. One of the strategies I tried when I was teaching was to declare at the very beginning that if there were any questions, when the questions in the exams, they would be from essential medicines. They would not ask questions from outside the essential medicines. Wonderfully focus the minds of students on essential medicines, because that was the way to pass the exam. Generic names exclusively in all areas. We actually told them, you write a brand name in your answer in the answer paper, you will get penalized. We actually didn't do it, but that made them write generic names on it. A presentation on the concept list and the implementation at the beginning of the course for them to understand, that would be useful. In a group, using the beta blocker that is from the essential medicines. Teach independent medicines information. Those days we had no app, we had the British National Formulary. But at the moment, the British National Formulary is available to all based on the smartphone application. If you do not have it, then I would consider it, if you do not have it on your smartphone, I would consider it a major defect. And for those of you who would want instructions on installing it, well, I will ask you to ask the Assistant Secretary, Priyanka Ranasinghe. I will send him instructions. You can have it on your phone. And that's the way to have fingertip. And then to show that and tell the students, yes, this is what I use as my reference. Ideally, we should have had a Sri Lanka hospital formulary on the app, but sadly, that is not to be so for many reasons. Give drug price information to projects to students. If a drug is prescribed, tell them to go to the pharmacy and find out. Sensitizes them to medicines prices. Give the patients basic drug information. Yes, you have now prescribed this particular medicine for hypertension. What will you tell the patient about it? And importantly, be a patient, be a partner with patients in health. I will end with a tribute to Professor Bibile, which was actually written by one of the students. And this is what he crystallized, and I totally agree with. While others were yearning for new scientific discoveries, he discovered a new science, the science of using drugs rationally, thereby transferring the advantage of modern medicines to the people who needed them most. Professor Bibile did not look for new drugs, did not look for other things. What he did was to say, how can we use what is available to the maximum benefit of the patients that we have in Sri Lanka? And this was by Dr. Sanjeeva Rangwala, who unfortunately passed away early, as was a student of the Faculty of Medicine, Colombo. And so, therefore, to conclude, what Professor Bibile achieved and the others in the first generation of clinical pharmacology, Professor Lionel, Professor Kotegoda, was unique, historic, and of enormous benefit to Sri Lanka and the world. And however, it is a constant battle to safeguard what they achieved. And as there are constant forces against it, it is the duty of those who share his visions, their visions, to nourish and encourage what Professor Bibile and the generation achieved. And I must say, after listening to the sessions on the Sri Lanka Association of Pharmacology, I have been very heartened by the presentations that came about, which showed that you are traveling, continuing the journey that was started off in the 1950s by our pioneers. And I would think that despite all the other factors, we are still on a good path for treating medicines as a part of health and to achieve that for the people of Sri Lanka. Thank you.
Thank you, Chrysanta, for that very interesting and historical presentation that you made. Thank you very much. All the way from Geneva, we can't thank you personally, but online we send our greetings and be safe.
Thank you very much.
Thank you very much, sir, for that thought-provoking lecture. And also to thank Madam for chairing the session, I would like to invite Professor Shalini Ranganathan to present a token of appreciation. Thank you very much, Madam. So with that, we are now coming to the very end of the proceedings today. We have had a very long and tiring day. Thank you for being online with us right throughout the day. I have one important announcement to make before we come to the final rites. The SLCAPT has decided to award 3 prizes for the presenters who presented their research papers today. The Best Poster Award, and then for the oral presentation, the first runner-up award, as well as the Best Oral Presentation Award. So I would now like to announce first the Best Poster Award. The Best Poster Award goes to poster presentation number 4, Knowledge and Adherence on Oral Anti-Cancer Medications of Patients Attending 3 Selected Cancer Clinics in Sri Lanka. I congratulated the presenter who joined online, and we will send your award and certificate in due course. And then moving on to oral presentations. The first runner-up of the oral presentation goes to oral presentation number 5, Determine the quality of extemporaneously compounded individual unit dose powders of furosemide and propranolol used in pediatric patients and improving the method of compounding. I congratulate the presenter once again, and we will send your prizes and the awards in due course. And finally, the Best Oral Presentation. The Best Oral Presentation Award goes to oral presentation number 3, Patient-Reported Outcome Measures to assess the effectiveness of inhaled medications in asthma. Once again, I congratulate the presenter, and we will make your award and prize available to you in due course. Congratulations. So thank you very much, ladies and gentlemen. Now we are coming to the last rites. To propose the vote of thanks, I would kindly invite Professor Shalini Sriranganathan, Secretary of the Association. Over to you, Madam.
Good evening to all of you. Probably this is the first time that I am speaking at last in a session, because most of the time that I speak within the session. And the second thing is, this is the first time that I am reading from something which has been written by someone else. So to make it quite brief, so I was asked to extend our sincere thanks, though we couldn't have these sessions in the traditional way we had it, to first to Person Narada Varnasuriya, who actually agreed to be the chief guest of our inauguration session, who couldn't do that, but anyway, he conveyed his message in our preceding books. And the second one is Professor Veerasuriya, who actually agreed to be the guest of honor of the inauguration session. Again, that we didn't have the session, but he actually communicated his greetings to us through the proceeding in our book. And then that I was asked to thank the overseas speakers as well as the within the Sri Lanka speakers who came online and did a very nice presentation, and also the presenters who came here and spoke in the plenary lecture as well as the symposium. In addition to that, I was asked to thank the people who have actually submitted the abstract, because more and more we are getting more abstracts in our presentation. Thank you all of you for bringing your abstracts and presenting either poster or oral presentation. And for Dr. Chamila Mithananda and her team, because she led the abstract review process, as well as there were 4 judges for poster as well as the oral presentation. And Dr. Roshini Murugupilla, as you can see, she had actually edited our 3 newsletters as well as started editing these our proceedings books, which I think Dr. Priyanka continued. Then I also want to acknowledge all the members of the council who have contributed this in various ways to have this session successfully. Actually, this is a new normal. We are not familiar how to conduct this session, but I think we have done a fair amount of work before this. So I like to acknowledge all those who have helped, especially our council members and the members of Department of Pharmacology, Faculty of Medicine, University of Colombo, who are always there to extend their support to all the 3 academic sessions we have had since the establishment of Sri Lanka Clinical Pharmacology and Therapeutics. Then also that I would like to thank all the research assistants worked in our department during the time that we were arranging. Actually, 3 rounds of research assistants were in our department. So I'm not naming all of them. That special thanks go to Dr. Nishadi Gamage, who was actually contributed a lot in especially designing that nice poster which was circulated to all of you, which also special thanks to her. And as usual, my dear staff, Priyani, Supun, Inoka, and the people who are not here like Mahesh, Iranda, Sainun, who have actually did the groundwork, which you won't see here, but which made this session such a nice and effective session. And Sarath, who has seen Mr. Sarath, who has been doing the photography. And I was also asked, the new normal has come, so the AV team contributed a lot to have this session successfully. So Mr. Kasun, as well as for his audio-visual team, thank you very much for having, though we initially almost got a heart attack to see that the slides are not coming well, but after that it was quite nice. Even from Geneva, Professor Veerasuriya said the projection was very good. So thank you very much, Mr. Kasun and your team. And also for the Colombo University Press for printing the program book. And like what we wanted, we managed to finish this session in a very low budget. So for that low budget, also some people sponsored, and I like to thank all our individual contacts who have actually contributed in a little way to conduct this session. And also the last, not the least, that I would like to thank the president and the staff of the Sri Lanka Medical Association for extending their support to have this session. But I must congratulate myself for one thing that I now learn. You can easily be a secretary of an association if you are wise enough to select the most appropriate assistant secretary. So I did that very wisely. So actually, I probably didn't do anything on my own when it comes to the session, whatever he asked me to do. So I did it. So my special thanks goes to Dr. Priyanka Ranasinghe, and I congratulate myself for selecting him as the assistant secretary of the Sri Lanka Association of Clinical Pharmacology and Therapeutics. Thank you very much to all of you. Thank you.
Thank you very much, madam. Ladies and gentlemen, that concludes the day's proceedings. Thank you very much for being online with us right throughout the session. And we do apologize for any technical glitches. We do hope to have the continuous interactions with you throughout the next few years, and do hope to have you in person maybe next year at the academic sessions. Thank you very much and have a pleasant evening.